Professor Injideka Okubadejo. Please, can you put your hands together for her? She's here. She's always on time. Please, can you just encourage her to come to the front? Thank you. All right. Please, if you are online and you are with us, we would like you to use the emoji to also appreciate our guest speakers as I call their names. Please put your hands together for her. Thank you very much. The next person is Dr. Alayo Shopekon. Please put your hands together for him. Put your hands together for him. We have Dr. Adeduni Wumi Olusonya. Please put your hands together for her. Dr. Kendi Olufemi Osusonya. Is he here? Okay. Online, we have Ota Akigbe. Please, can you celebrate her? Please celebrate her. She's online. Can you celebrate her? Media, please, can you help us spotlight those of the panelists that are online, please? Thank you. We have Dr. Olubinga Fadikwe. Are you around? Okay. I guess he's coming. And we have Barrister Ufoma Emore. Please, can you celebrate him? He's one of our panelists, PD champion. So for our online participants, we have Professor Marcos. Professor Marcos, please, can you spotlight the people online, please? Media. Frafunda, Professor Marcos Frafunda, please, can you celebrate him? He's online. Please celebrate him. Thank you very much, Professor, for joining us. We also have Professor Kimberlyn Campanello. Please, can you also, please, why are we cold? Do you need me to ginger you to clap? Or is the AC too much for you? All right, if you don't want me to stand you up, please, let's appreciate our panelists as they come. So I will be bringing the founder and chair board of trustees to come for the opening remarks, and she will be introducing our keynote speaker for today. And when the time comes, we'll bring her up for the keynote address. So please put your hands together for Mrs. Maureen Desalu. Can you put your hands together for her? Please put your hands together for her. Thank you. Don't stop clapping, no. Don't stop clapping until she gets here. I'll bring that.
Thank you. Good morning. Good morning, everybody, and welcome to the 4th Annual Symposium of the Adeomi Desalu Parkinson's Foundation. My name is Maureen Desalu, as he's told you, Chair of the Board of Trustees of Adeomi Desalu Parkinson's Foundation. As I say, founder, but founder and the widow of, and very, very emotionally satisfied to be doing this work. I stand on behalf of the patrons, the trustees, the governing board, the advisory board, the executive team, people with Parkinson's in Nigeria and their families, to thank you for joining us today, 11th April, World Parkinson's Day. To the people joining us virtually, we're grateful. Some of you are in very awkward time zones, but still you're up and you're with us. Thank you. April is World Parkinson's Month, and it is our mission to make as many Nigerians as possible aware of this disease, which is the second fastest spreading neurodegenerative disease in the world today, after Alzheimer's. We're trying to build statistics in Nigeria and hopefully in Africa to share with the world. It's important that we know that Parkinson's is no longer an old white man's disease, because there are many women and young people who are living with Parkinson's disease today. So today we gather as a people, as a community, to look at how this is affecting our brothers and sisters and their families. We stand with the community of people with Parkinson's and say loudly that you are not walking alone. We are all walking with you. We will hear more as the program unfolds. Today we are grateful for the expertise of our own nationals in this area and their focus on movement disability. We celebrate our own Professor Njideka Okubadejo. Louder. Who is going to deliver the keynote address, From Innovation to Implementation, Building Resilient Parkinson's Care Systems in Nigeria and in Africa. We're all excited and look forward to learning from her. She's a busy woman, but God released her for us in Nigeria today. As often in the years past, on World Parkinson's Day, she's somewhere else in the world. But we're grateful. We're grateful for all our panelists. Dr. Ibrahim Akumi Mustafa, wave if you're here or online. There he is, he just came in. Dr. Adeduni Wumi-Olusoya, nice to see you. Dr. Alayo Shokpekon, did I get that right? Shokpekon, yes. Thank you. Yes, Shokpekon, correct, Shokpekon. Thank you. Miss Ota Ahibe, I think she's online. Yes. Barrister Ufoma Emore. I have Dr. Emanuela Zamba. I don't know if she's online. John mentioned Dr. Kehinde Olufemi Oshosoya and somebody else. I think I might have missed that name. I apologize if I have missed your name. Professor Marcus Fraundorfer, Professor Kimberly Campanello. Together, we shall discuss integrating primary Parkinson's care into primary and community health services in panel 1, and building resilient Parkinson's care ecosystems through workforce development, partnerships, and sustainability in panel 2. We shall end each panel session with a question and answer session, so please scratch down questions as we go along. While we cannot fix all the problems today, the journey of 1,000 miles begins with one step. Let us try to take a few steps today. It is our prayer that today is a learning process for us all, and that when we leave here, the Parkinson's community in Nigeria and the supporting ecosystem will. This is supposed to be a short welcome, and it is best that I stop here and invite Mr. John Akinola back, our head programs at the Adeomide Salu Parkinson's Foundation, to take the next set. Welcome again, and good morning. Thank you.
So please, another round of applause for Mrs. Maureen Desalu. There's a lot that we need to say, but we need to manage the time. And so before she gets to her seat, I know she mentioned something that is second.
And now I'm 73. By the grace of God, I am a civil engineer by profession. Because I was the minister in the judge. So, but one of the time I was taking the seminar, my wife noticed that my hand was shaking.
My name is Mrs. Ifai Deborah. I'm 46 years old. I'm a petite trader and a single mother. I have 6 children that I'm taking care of. Normally, before this Parkinson starts, I'm a hustler. I do my business.
Okay, Dr. Olugbenga Fadipe. Thank you very much. Okay, she's representing the Dr. Emanuela Zamba. So I would like to call on Mrs. Desalu. Mrs. Desalu, to please help us with introducing Prof. Njideka Okubadejo. Yes. She has insisted that she's not climbing. All right.
Thank you. Thank you. Thank you. Thank you. I only came down because there was supposed to be something else. A professor of, in fact, let me start the other way around. A woman, an Amazon, a professor of neurology and consultant neurologist at the College of Medicine, University of Lagos, and Lagos University Teaching Hospital. Idiaraba, Lagos. You students, you know these things don't come easy, so we better clap loudly if you are heading in that direction. Yes. Professor Njideka Okubadejo is chairperson of the Africa Section Steering Committee of the International Parkinson's and Movement Disorder Society. When I finish the sentence, you will clap. She is the Neuroscience Thematic Area Coordinator of the National Institute of Health sponsored Building Research and Innovation in Nigeria's Science, brains, Building Research and Innovation in Nigeria's Science, brains. Mentored research grant at the College of Medicine, University of Lagos. Loud it. Mm-hmm. She pioneered the establishment of the Youth Movement Disorders Clinic as a platform with a tripartite of
cure for it right now, or if it is managed properly, there's hope. And it has to do with supporting the caregivers because of the good work that
and principal investigator in the national study on the genetic
collaborations and the sponsorships that we can get to support us.
The NIH USA of the first Michael J. Fox Foundation research grant supporting Parkinson's disease genetics research in Africa. Her main research interests are neurodegenerative disorders, movement disorders, and strokes. Her passion is fostering collaborations that build capacity for research and mentorship to ultimately improve the quality of care and outcomes of Africans with neurological disorders. Please join me to welcome Professor Njideka Okubadejo to deliver the keynote address. I salute ma.
Good morning, everyone, and thank you for having me. Let me start by saying that Maureen is actually my cousin. I'm not sure many people realize this. And you can get the details from her later. But I want to first of all thank the Adewumi Desalu Parkinson Foundation for the tremendous work that you're doing with respect to directly impacting the lives of people with Parkinson's disease in Nigeria and really being a model for the rest of the country, but also the rest of the world as to how support can be provided to ensure that it directly reaches those who are most affected. So many times, the things that we do with respect to addressing Parkinson's disease are very remote from those who are actually affected by the condition. But in this instance, the ADPF is directly working with people with Parkinson's, ensuring that they understand their lived experience and innovating along with them ways of ensuring that the quality of life that they ought to have is gradually being achieved. So thank you very much, Maureen. And thank you to the foundation. Also, thank you for having me. I will give my address. I'm hoping that the slides are showing somewhere. Okay, so I guess you can see them sort of cut off at the edge, but that's fine. So I've been asked to talk about building resilient Parkinson's care systems in Nigeria and Africa, and that's really the theme of the talk this morning. But I thought I will first of all break down that title, because when I heard that title, it sounded like something from the corporate sphere, and maybe many people would not understand what that means. So what it really means is we're trying to find new ways to help people with Parkinson's and making sure that those solutions actually work and keep working in Nigeria and in Africa. So next slide. Am I to trust the person who's changing these slides? Great. All right, so next slide. So today is World Parkinson Day, April 11. And it celebrates the birth date of the person who first described Parkinson's disease in a way that he put it together and published it in a medical journal for visibility. Of course, he wasn't the first person to recognize that people could shake or be slow, but he was the first person to concisely document what he had seen, put it together in form of a publication, and he was the first person to begin to give it that scientific awareness that has led us to where we are today. And his name was James Parkinson. And so the day is named after him. And if you're a social media person, please follow the hashtag World Parkinson's Day, drop comments, post photos, and so forth. Now, why is it important that we talk about Parkinson's disease? So yes, what Maureen said was right. She said Parkinson's disease is second only to Alzheimer's in terms of neurodegenerative disorders. So in terms of the commonest neurodegenerative disorder, Alzheimer's is first, Parkinson's is second. But in terms of the rate of growth the number of cases that are being seen, Parkinson's disease is known to be the fastest growing neurological disorder worldwide. And this is really important. And it's not just hype. It is based on work that has been done by a group known as the Global Burden of Disease Group. And they've continued to show that between 1990 and about 2016, the numbers of people with Parkinson's disease has continued to increase all over the world. Previous slide. Okay, and if we're interested, we can look at the details of that. Next slide. So, other people have looked at this data to see how credible it is and what it really means for us in the scientific community, but also what the real numbers are. And in this slide, you'll see that about 25.2 million people are expected to have Parkinson's disease by 2050. It means that all over the world, there's going to be almost 122% increase in the number of persons with Parkinson's disease in a short while. Next slide. Now imagine that 25.2 million people is the population of Ghana, for instance, and slightly less than the population of Lagos and Ogun State combined. Now, why is this important to us again in Africa and in Nigeria? Well, it happens to be that the largest increase in the number of persons with Parkinson's disease is estimated to occur in Western Africa and in Eastern Africa. So Western Africa is going to experience almost a 292% increase in the number of people with Parkinson's. And Eastern Africa is expected to experience almost 186% increase in the number of people with Parkinson's between 2021 and 2050. And why is this happening? First of all, our population is aging. So believe it or not, even though they set our life expectancy as in the mid-50s, we're having a higher and higher number of people in that age bracket, 50 and above. The second thing is that because of the increase in the absolute numbers of our population, then it means that more people are at risk of the disease. And then thirdly, there seems to have been a notable increase in the occurrence of Parkinson's disease. Again, that has different reasons. So some people talk about westernization or urbanization, exposure to industrial chemicals that can increase the risk, but also increase in the numbers of people that are being diagnosed because we're increasingly recognizing Parkinson's disease. So, like Maury mentioned, we sometimes are disadvantaged because we don't have credible data. But what we've been doing, what we've realized is that understanding, one, that from clinical experience and from the experience of seeing people with Parkinson's, we who practice neurology in Nigeria and in Africa do not subscribe to the notion that Parkinson is less common in Nigerians or in Africans than it is elsewhere. And we now have proof that this is the case. So Parkinson's is as common as it is elsewhere in the world in Nigeria. So we've used those global figures that tell us that worldwide, about 0.04% of the population below 60 will have Parkinson's. And then about 1% of those aged 60 and above will have Parkinson's. So we've applied those numbers to our population fraction aged below 60 and 60 and above. And we estimate that in Nigeria alone, in Africa alone, there are about 1.2 million people who have Parkinson's. Now we think that this is even still a conservative estimate. Next slide. So why are we talking about moving from innovation to implementation? Why is it important that we find new ways of improving the outcomes of people with Parkinson? First, people with Parkinson's need healthcare workers who are skilled in diagnosing Parkinson's early. I greet Parkinson's community that are here with us today, and thank you for joining us. And I know the journeys of many of us prior to even getting the first diagnosis, it's often delayed. In the studies that we've done, on average, people with Parkinson's, it takes about 2 years from when they initially develop their symptoms to when someone mentions to them that they might have Parkinson's. The second reason is that people with Parkinson's need healthcare workers who are skilled in treating all the complaints of people with Parkinson through all the stages. So we realize that Parkinson has what we call motor features. So tremors, shaking, stiffness, difficulty with walking. But they also have what we refer to as non-motor symptoms. Problems with sleep, problems with control of bowel, and so on and so forth. And because of this, people need to be trained to help manage all these complaints. And not just in people who have early, mild symptoms of Parkinson's, but those with more advancing disease. And so Parkinson's is managed by a multidisciplinary team of specialists, neurologists, other physicians, nurses, physiotherapists, speech therapists, occupational therapists, nutritionists, to name but a few. And so all these healthcare workers need to be skilled in the treatment of Parkinson's. People with Parkinson's also need access to medicines and treatments that are affordable and available. We often talk about the most basic, which is levodopa or Sinemet access. But we realize that if you're looking into the literature, you know that there are so many other drug treatments and non-drug treatments and surgical therapies that can help people with Parkinson's. People with Parkinson's need to be supported to have a better experience and better quality of life. And then Parkinson needs to be a public health priority, given how many people are affected by it. So we don't have to reinvent the wheel in terms of understanding what we need to do to get to where we're trying to. So the World Health Organization has been very active in recent years in helping to promote awareness regarding Parkinson's disease and to get governments to do right by people with Parkinson's. So a couple of years ago, along with other colleagues, we worked with the WHO to come up with these 6 action steps to address global disparities in Parkinson's disease, and I'll just summarize them. They identified 6 areas and also identified 6 steps that can be taken to address them. So the first, of course, is lack of quality data, epidemiologic data, meaning data that tells us without a shadow of a doubt that this is a number of people that have this disease. Why do we need this? This is what governments use to make decisions. So if you listen to policy and so forth, you will sometimes hear that they are taking decisions based on under 5 mortality. So because they know how many children under 5 do not survive, they can then use those numbers to advocate for actions to be taken and policies to be made to improve mortality. So likewise, we need credible data. And now we have it though, because the first thing you can say to a policymaker is, well, Parkinson's is the fastest growing neurological disorder worldwide. And you can get the attention that way. We need, the second step is, the second problem rather is lack of awareness. And the ADPF along with others are doing a great job already in that regard. The third is lack of risk reduction and prevention strategies. Because whereas it's really important to treat people with Parkinson's and to support them, what would ultimately be most beneficial is if we can reduce the risk and prevent the disease. And you can only reduce the risk of a disease where you know what the risk factors are. And we're increasingly understanding, for instance, that physical therapy, exercise, is one of the key measures that can help reduce the risk and possibly slow the progression of Parkinson's disease. Next slide. So lack of access to diagnosis, treatment, and care is another problem. And the action step is to develop culturally and socioeconomically acceptable models of care that are multidisciplinary, that are affordable. So what does that mean? So for instance, rather than just adopt how care is provided in Western countries, because the health systems are different, we need to look inward and see how we can work with people with Parkinson's and develop innovations that are relevant to our own culture. Then lack of caregiver support. So people who care for people with Parkinson's, I hail you. I know many of you are here. Caregivers also have their own burden. And so providing an accurate and timely diagnosis is important, because if a person with Parkinson's is doing well with their treatment, then the burden of the care on the caregiver is less. But also training and educating caregivers so that they can provide better care for people with Parkinson's disease. And then the final action is related to the lack of research, coordination, and investment. So if a condition is not prioritized, people who give grants for research or governments will not commit funds to it. So this is another area where we need to take action. Next slide. So the WHO has been very active, like I mentioned. And in recent years, they put together 2 policy documents that governments, advocates, other stakeholders can use to understand what they should be doing for people with Parkinson's. And these 2 are publicly available. So in fact, in the second document, Improving Access to Medicines for Neurological Disorders, they used Parkinson's disease as an example of how we can improve levodopa access worldwide. Next slide. And in that document, they really identified all risks for why people may not get levodopa, so that anyone who's trying to advocate for levodopa access can identify where they can step in terms of the bottlenecks and where they can act. Next slide. So in all of this, partnerships are key and they improve synergy. There's that African adage that says if you don't want to go far, go alone. But if you want to go far, go with others. Because there's really so little that you can do in silos. So I just want to highlight a couple of the partners that have been working together in Nigeria and in Africa to address Parkinson's disease. And I apologize for any that I have missed out. It's not intentional. So the Nigeria Parkinson Disease Research Network is a group of about 50 neurologists spread across the country who are researching different aspects of Parkinson's disease. TRAPCAF is the Transforming Parkinson's Care in Africa project, and it's a 7-country project funded by the UK NIHR, where we're doing a lot of things regarding Parkinson's. We're gathering data from door-to-door surveys to understand how many people have Parkinson in our communities. We're also working with foundations like the Parkinson Africa and ADPF to strengthen support groups and community engagement for people with Parkinson's and so forth. Of course, there's Parkinson's Africa that is led by Omotola, and is working also very actively with ADPF. There's, of course, the ADPF, the International Parkinson and Movement Disorders Society, whose primary mission is education for movement disorders, of which Parkinson's is the most common. They're working very actively. They have a section in Africa, and they provide probably the most education for people with Parkinson's, for healthcare workers, to be able to treat people with Parkinson across all of Africa. And then we have the Global Parkinson's Genetics Program that is deploys its funding through the Michael J. Fox Foundation and funds our understanding of the genetic basis of Parkinson's disease in Africa. Next slide. So this is just to acknowledge the Nigeria Parkinson Disease Research Network. You can see all the pins where we are across the country. It means that in virtually every teaching hospital in Nigeria, if a person with Parkinson's disease goes there, they will see a neurologist with interest in their disorder. So what is the outcome of these synergies? Very quickly, the first is healthcare worker education is taking place very actively all across Nigeria and Africa. So for instance, the Movement Disorders Society has what they call the Train the Trainer program, where they train academic clinicians, neurologists, physiotherapists, who then go to their countries and deploy this training virtually. There's stakeholder engagement with policymakers like ministries of health. The WHO is actively engaging with ministries of health, using their documents across African countries. There's public awareness. ADPF is doing that extremely well. There's support for people with Parkinson, their carers. This is also actively ongoing. like ADPF, there are many support groups, not as many as we would like to have across Africa. There are national and multinational research networks energizing on sustainably improving access to medicines. So I chair a committee called the Committee for Equality of Access to Care in the Movement Disorders Society, and it's a multi-stakeholder committee that is looking at how we can identify countries, underrepresented countries, and work with the WHO to improve access to levodopa in those countries. There's also another committee that has been formed by the Parkinson Foundation, which is a European charity that is also a high-level multi-stakeholder initiative that's trying to ensure that people with Parkinson's get the treatments that they need all over the world. Next slide. So the key players in advancing Parkinson's disease education in Africa include the International Parkinson and Movement Disorder Society that have possibly made the greatest investment in training healthcare workers in Africa to be able to manage Parkinson's disease. But we also have African academic and research institutions and neuroscience professional organizations. And I mention them because that's the way to sustain it, because we can then have Parkinson's disease in the undergraduate medical, nursing, physiotherapy curriculum, so that as we're training students, they already know what Parkinson is. The European Academy of Neurology and their partners have been conducting regional training courses in Africa for more than 15 years. Different African countries gathering together trainee doctors to train them on neurologic disorders, including Parkinson's disease. There's the African Academy of Neurology, the World Federation of Neurology, the WHO, the Global Parkinson's Genetics Program, and the Edmond J. Safra Foundation. Next slide. So just as an example, quickly, the Movement Disorders Society in 2024 had almost 3,000 course attendees trained on Parkinson's disease. And of these courses, we had 10 in-person courses in 10 African countries, just for example. And we're doing this both in Francophone and Anglophone countries. Next slide. The MDS Train the Trainer is a program initially for allied health. Like I mentioned, they will train a physiotherapist, preferably in an academic position, who can then go back and train others virtually. And the current MDS Train the Trainer is actually directed at doctors in primary care, so they can train more people to diagnose Parkinson's at the primary care level. Next slide. I mentioned the European Academy of Neurology regional training course that has trained more than 1,000 neurology residents and other residents across those African countries. And usually, if it's holding in one country, they will bring in residents from other African countries. Next slide. So these are just some of the pictures that have kept us very busy, going from one African country to another every year to do these trainings. Next slide. And more trainings. Next slide. More trainings still. So I talked about data and credible data. So one of the things that TRAPCAF has achieved is that we now have data from door-to-door surveys in 4 African countries that tell us how many people have Parkinson's disease, the rates of Parkinson's disease in the community. So one of them was done here in Lagos, in Mushi and Surulere local government area. And like I said, when we calculated the prevalence of Parkinson's disease and standardized it to global rates, we found that the rates were similar to what is taking place worldwide. Next slide. So these surveys have also been done in Tanzania, in Ghana, and in Kenya, and we're about to publish those results. Interesting to mention that now the Global Burden of Disease study is going to incorporate this data to now, for the first time in 2 decades, give us credible data that describe Parkinson's disease burden in Africa. And my final slide. So the key pillars for action, going from just doing things piecemeal to multi-sectoral approaches, include continuing to enhance diagnostic and clinical capacity, leveraging technology for access, so building digital resilience so that we can begin to think about things like telemedicine and so on, developing sustainable medication supply chains and insurance coverage, and then community engagement and stigma reduction, and promoting research and collaboration. Thank you very much.
Please put your hands together for her once again. I believe you have learned a lot of information about Parkinson's in Africa and Nigeria as a whole, right? Thank you very much, distinguished ladies and gentlemen. We really want to appreciate you for coming. And to our keynote speaker, Professor Njideka Okubadijo, thank you very much, Ma, for that outstanding keynote speech. Please, if you have any question, please would like you to take note of it, and you can pass it to the ushers or the volunteers. She's going to be a little bit around for a couple of minutes to attend to questions. Please, if you have questions, just signal the volunteers. Thank you very much. Next on our agenda is ADPF Impact Report. Impact report for what the foundation. So when you hear ADPF, it is Adewumi Desalu Parkinson's Foundation. Do you understand it? Right. Thank you very much for that. So please, media, can you put up the Adewumi Desalu Parkinson's impact report? Thank you. Okay, while we wait for the media, we don't want to waste time. Distinguished guests, we want to appreciate you. We reached out, as the foundation, we reached out to a lot of stakeholders to join us today for this event. And we have some people in our midst that I would like us to appreciate their presence. Members of the Federal Road Safety Corps, Lagos State, please can you put your hands together for them? They are in our midst. Can you just rise for recognition? Thank you very much. Thank you very much. We also have representative from LASMA, the Lagos State Transport Management Agency. Can you please appreciate? Thank you very much for coming. Thank you very much. We also have members of the police force, Nigerian Police Force, Lagos State. Please, if you are here, can you? All right. I guess she's coming. So, media, are you ready for us? Okay. So we have, yes, we have Dr. Olugbenga Fadigbe. Please, okay, yes, you are here. I've introduced you. Thank you very much for coming. We have also Parkinson's Africa, people from Parkinson's Africa. Can we please celebrate them? They are here with us. They are here with us. Thank you. All right. So while we wait for the media to come up, I will just please permit me to introduce all our panelists and give you Olusanya. She's a consultant neurologist, senior lecturer at UNILAG, and a medical director of Carville Health Medical Services. With over 2 decades of expertise in brain health, her research specializes in genomics of Parkinson's disease and women neurology health. She's an active member of the Global Parkinson's Genetics Program, and she's also the founder of Brain Health Haven, a digital platform dedicated to community neurological health awareness. Please put your hands together for her. So you know that that is a very rich panel. Thank you very much. Also, in that panel, we have Dr. Kende Olufemi Osusonya. Dr. Kende Olufemi is a Deputy Director and Service Delivery Program Manager at the Lagos State Primary Health Care Board, with 15 years of expertise in primary health care management and health system strengthening. He has led primary health care delivery across multiple local government areas in Lagos and currently oversees performance monitoring and data-driven decision-making in the board, holding both the medical officer of health. He also has a degree in MPhil and MBA with distinction. That's a very good one. Please put your hands together for him. Thank you very much, please. Thank you very much, sir. Thank you. So, and the last but not the least is our, so just give me a second, please.
Let's reflect over the last few.
Sorry, please, I cannot place my hand on Professor Marcos Falfander's profile. I will get it across to you immediately. Media, are you ready? Can we go ahead, please? Thank you very much. ADPF Impacts Report.
Disease Symposium. First, core, the vision remains clear. Support people impacted by Parkinson's disease across Nigeria and ultimately West Africa. Our mission drives us daily to advocate for people living with Parkinson's, expand access to care, and contribute meaningfully towards finding a cure. Through the years, that mission has come to life through a range of programs designed not to just treat symptoms, but to restore dignity, independence, and hope. Our rehabilitative care programs continue to be at the heart of our impact. Since 2022, we have worked to ensure that people living with Parkinson's disease have access to critical therapies that improve daily living. In 2025 alone, we delivered over 2,000 rehabilitation sessions and reached more than 90 individuals living with Parkinson's, while also supporting over 250 caregivers who actually are the often unseen pillars of this journey. Through neurophysiotherapy, we have helped individuals regain strength, mobility, and confidence. Our program, addressing micrographia, a common symptom affecting handwriting, have enabled measurable improvements for many participants. And through innovative approaches like rock-steady boxing, participants are building coordination, balance, and resilience in powerful new ways. But care goes beyond physical therapy. Our dance sessions have supported close critical gaps in access to specialized care. Equally important is the power of community. Our monthly support group sessions provide a safe, welcoming space for individuals and families to connect, share experiences, and access accurate evidence-based information. These sessions are a reminder that no one has to navigate Parkinson's alone. In 2025, our events amplified both awareness and engagement. From the Parkinson's Disease Symposium, which brought together experts, caregivers, and advocates, to the World Parkinson's Awareness Day activities, we have continued to spark important conversations and drive visibility for a condition that is still wildly misunderstood. Our awareness campaigns have reached even wider audiences. Initiatives like the annual Move for PD Awareness Walk has mobilized hundreds of participants, while the documentary Beyond the Tremors, Living with Parkinson's Disease has brought real stories of Parkinson's in Nigeria to life, helping to humanize the condition and inspire both empathy and action. These efforts are not just about numbers, though the numbers are significant. They represent lives touched, families supported, and a growing movement of awareness and advocacy. Behind all of this is a commitment to transparency and sustainability. In 2025, most of our operational resources, over 70%, were directed towards programs and activities, ensuring that our work remains impact-driven and community-focused. As we look ahead, the importance of collaboration cannot be overstated. Parkinson's disease care in Africa still faces significant challenges, from late diagnosis to limited access to specialists and therapies. But within these challenges lies opportunity. Opportunity for innovation, partnership, and systemic change. Today's symposium is a reflection of that opportunity. It brings together voices across healthcare, research, policy, and lived experience to shape the future of Parkinson's care in Nigeria and beyond. It is a space for dialogue, for learning, and for building the partnerships that will define the next chapter of our work. As we move forward, one thing remains certain: the journey is far from over, but with every therapy session delivered, every caregiver supported, every awareness campaign launched, and every conversation sparked, we are moving closer to a future where Parkinson's disease is better understood, better managed, and ultimately cured. Thank you for being part of this journey. We look forward to what we will build together.
That's just a summary of the impacts the Adelby Desalu Parkinson's Foundation has provided to the Parkinson's community. And you are also making that history with us today, April 11th, World Parkinson's Day. Thank you very much. And also put your hands together for yourselves for being here. Thank you very much. We have few questions here, and I will just read the questions, and I'll give Prof the opportunity to answer the questions all at once. Okay, I'll just take them, 3 questions, then she will answer. I have, okay. All right, please, Mark, how can we prevent constant falling of Parkinson's patients? That's first question. Is Parkinson's disease acquired, or is it incidental or genetic, or all of the above? The person is asking. And the third question for...
That mission has come to life through a range of programs designed not to just treat symptoms,
how
to restore dignity,
this person is...
independence, and hope. Our rehabilitative care program
Parkinson's disease can be a cause of falls, and so they're important to engage in physical therapy. So you see, helps you your balance also. So doing physical therapy in preventing falls. However, As Parkinson's disease progresses, it may be inevitable that you require support for walking, for mobility. So at that point, the physiotherapist should assess the person's gait and then advise as to whether they need to walk with a tripod or a walking frame, or whether indeed they need to be in a wheelchair. So it's important also to report falls when you see your doctor regularly, so that give you advice about how to do what. So that's one. The second question, cost of. So to simplify, about 10% of all over the 15%. Now the Parkinson's disease. And the cause is a combination of genetic predisposition and environmental factors. So what I said is that the person has inherited the tendency to have Parkinson's disease, or is likely to have inherited that tendency. And then the person is exposed to things in the environment. Sometimes we don't know what those things are. And then
continue to be at the heart of our lives. Since 2022, we have worked to
true. You know that
have access to critical therapies that improve daily living.
environmental exposure. So you may have been reading about trichloroethylene and some other chemicals that can actually cause Parkinson. So those are the causes. And that is probably why it's a bit difficult to arrive at a cure, because if it was only one cause, then all the effort would be directed at finding that cause and treating it. Now, why is there no cure? I think that we're on the path towards a cure, and that is what all the efforts in research are geared towards. And like I said, the difficulty in finding a cure is because of how complex Parkinson's disease. But I must also say, because of how deprioritized it was in years past. But we're hoping that with the increased focus on it now, we will eventually find a cure. Thank you.
Thank you very much, Ma. This next question is more of an observation, and the person is asking, in summary, the MDS Train the Trainer program. I observed that healthcare workers do not consist of pharmacists. Are this the first point contact in the community? I believe they have a vital role to play to access medication and awareness, especially the education of choice and medication counseling, adherence, monitoring, and the likes. Okay, that's one observation. The second one is, okay, this is now a question. How do we confirm if a case of Parkinson's is genetically related or not? How do we confirm if a case of Parkinson's is genetically related? Can you hear me? Okay. Sorry, I can't see this question very well. Are neurologists involved in research and treatment of Parkinson's? Yes, neurologists, yes. Or neurosurgeons, sorry. The question is, are neurosurgeons involved in research and treatment of Parkinson's disease? Okay, I guess what this person is trying to say is that how can Parkinson's disease be dictated early before the signs? Those are the questions, ma. Thank you.
Okay, thank you again for your very insightful questions. So the inclusion of pharmacists, I just wanted to mention that the Movement Disorder Society membership is actually open to all health professionals. And it's really a matter of just pushing and advocating for a cause for pharmacists. I know that we've had some silos where we've brought together pharmacists to do some awareness and training, but we can certainly do better. Now, how to confirm if Parkinson's is genetic. So the first thing I wanted to share with us is that we have been looking at the genetics of Parkinson's disease in Nigerians. Altogether, we've looked at nearly 4,000 people with Parkinson's and compared them to about 5,000 healthy, unrelated people. And one of the things that we found about 3 years ago was that there is a factor. So when I say risk factor, it doesn't mean that you would definitely have Parkinson's, but it increases your risk. There's a risk factor that is novel and almost entirely confined to the West African population that increases the risk of Parkinson and is present in about 40% of those with Parkinson in Nigeria. So in Nigeria, we know that the majority of people with Parkinson carry this risk, about 40%. When we compared them to Black Americans, who we all know most of them came from West Africa, we also found that same risk factor to be a factor that increases risk of Parkinson's disease in African Americans. So it's a risk factor in the gene called the GBA1 gene. And we published this a couple of years ago. What it means to us is that, one, even though GBA1 gene variation is the #1 risk factor for Parkinson all over the world, the particular variant that increases risk in people of West African and Black American origin is different from that for the rest of the world. And that information is being used to see if we can direct a treatment to reduce the impact of that GBA1 variant. Now, how else can we know? It's by doing research, but for an individual who wants to know his genetic risk, there are some known genes that can be tested in a lab. It's pretty expensive, but there are about 7 or 8 genes that can be routinely tested for in the lab, especially if a person
2018 to 2021 before I was able to be diagnosed.
My name is Empress Priscilla Omoijade. I am 41 years old and I'm into organic production for hair and for skin. Before I got diagnosed, I think that particular period, I was still working. I discovered that I couldn't write properly as fast as I used to. Trying to bring out money from my purse is always difficult. So some people will be like, why are you so slow? And they'll be using language on me like, I'm too slow, maybe something is wrong with me. Some people saw me as someone with communicable disease.
My name is Laura Timitoyo Ede, and I'm the Executive Director of Adewumi Desalu Parkinson's Foundation. Okay, so Adewumi Desalu Parkinson's Foundation is a non-profit organization that deals with the rehabilitative care of people with Parkinson's disease.
ADPF is an organization that is set out to provide care and support. Aside care and support, we do awareness.
For anyone who is newly diagnosed with Parkinson's, it can be a huge shock. It can be overwhelming to hear that you have been diagnosed with a disease that has no cure or has no cause, no known cause. I just want you to know that the Adewumi Desalu Parkinson's Foundation is where you will find care and support.
So I'd like the public to know that Parkinson's disease is not a death sentence, although there is no cure for it right now, but if it is managed properly, there's hope. And it also has to do with supporting the caregivers. Because of the good work that we do at Adewumi Desalu Parkinson's Foundation, we are all for all the partnerships and the collaborations and the sponsorships that we can get to support us to be able to do the good work.
Thank you very much. That is just the trailer of the documentary. The documentary is a 20 minutes long documentary. You can, if you, like I said, once you scan the barcode that the media is going to be showing, you have access to all of this information. You can later check on the information. Thank you very much. This is the time for the first panel session. And we want to appreciate everybody for waiting and for participating this long. And before I start calling our panelists to come on board, I just want to read the profile of Professor Marcos Frandafa. He's an associate professor of global governance in the University of Leeds. His research explores how to reform global governance to address global challenges more effectively and equitably. One of his research strands to the global health and global politics of neglected diseases. His last book, Pharmaceutical Knowledge Common for Most Neglected Population in Global Health, analyzes the role of Drug for Neglected Disease initiative in development and distributing novel treatment for neglected diseases and affected population. So he has worked and studied in the University of Sao Paulo and the Catholic University of Rio de Janeiro and the University of Brasilia. So please put your hands together for Professor Frandafa. Please put your hands together for him. And I would like to just call on our panel one panelist to come up stage for the first panel session. Please put your hands together for Dr. Alayo Shopekon as he come up stage. Dr. Adeduni Olusonya, Dr. Mrs. Adeduni Olusonya, please put your hands together for her. Dr. Kendi Olufemi Osusonya, please put your hands together for him. Thank you very much. Um, and of course, Professor Falfonder, Marcus Falfonder is sorry, please. Apologies, please. He's online. He will be joining us online for this session. So. All right, please, can you just do text to microphones?
Hello.
Thank you. All right. Thank you very much. Okay. The topic for our discussion today and this panel is integrating Parkinson's care into primary health care sectors. And what we want to achieve is to see how we can integrate the care of Parkinson's into the community health care sectors and the primary health care ecosystem. So I'll be asking some series of questions and just, get your idea into it. So first and foremost, I'll start with you, Dr. Mrs. Adeduni. Please, can you just tell us how we can integrate Parkinson's care into the primary health care system, based on some of the things that you have observed and your experience in the Parkinson's ecosystem? Thank you.
Thank you very much for the question. I guess I'll start by telling a story that resonates with all of us. So over the years, I've seen a lot of people who come in with PD. They'll come into the clinic, they are slow, they have tremors, they are quite rigid. And, looking at them, advanced phase, and so what comes to mind is he has not taken his medication today, or he has not taken his medications in days, or the dose is just not enough. So you go asking questions, and you discover this is the first time this person is coming to the hospital to see someone for something they don't know. And when you are mentioning Parkinson's disease, it sounds so odd. It's something some people have never heard about. And when you're trying to find out more, you're asking questions like, how did it start? So you get answers like, I noticed it when I had the wedding for my daughter. It was very successful. Some of my relatives were not happy, so I'm suspecting it came from one of them. Some of us can resonate with that. Then the other thing is usually for men. My wife forced me to come. I think I'm just getting old, and it's expected to be slow and maybe have tremors. So how do we address that? So the first thing is creating awareness. So if people don't know, then there won't be patients coming in. So we need to get people to know. We need to go out there. I know a lot is being done, but a lot more has to be done, especially in the rural settings where people can understand this. Just like I know when people, all these jingles, the adverts, we might need to go that way. Then the other thing I noticed too is some of them will come in. Yes, I actually saw a doctor. He said I had arthritis. And they keep treating arthritis for years. They're not getting better until they seek a second or third opinion. How do we improve care? By educating healthcare workers, the people at the forefront. I'm talking of medical doctors, nurses, pharmacists, community health workers, people that educate the community. They are the ones at the forefront, and if they have an idea about this, they would be able to solve the problem. And finally, some of them will actually say, I started medications 2 years ago. It didn't go, so I left. So advocating proper care structure. So when the patient comes once, that's not just all. They need to be educated. They need to be transferred to specific places. I guess we'll be talking more about that, but I think this answers the question for now. Thank you.
Thank you very much, Dr. Bisadeduni. Let me come to you, Dr. Alayo. Many people living with Parkinson's in Nigeria are diagnosed late. Often, symptoms have significantly progressed. When symptoms have progressed, from your perspective, what needs to change at the community or primary healthcare system?
Yeah, thank you for the question. I think that's a very good question. Yeah, most of the time, for chronic illnesses like Parkinson's disease and other chronic illnesses, they are chronic and they are actually progressive. So, and for us, we believe that early detection is the best way to go. And if you are going to do that, it means we need to go back to the community, just like we have had here this morning. We need to go back to the primary health care level. And, the thing is that before now, our primary health care level structure is such that we structure it to address communicable diseases. Before now, many people here will agree with me that before now, PHCs are regarded as just maternity centers where women just go to deliver, and then you go back there to give your child immunization, or you go there for vaccination and other things. But that non-communicable diseases, because Parkinson's disease is a non-communicable disease, So as you have heard here this morning, and for those who don't know what non-communicable disease is, they are those diseases, as we are sitting down here, you can't transmit it to another person, even when you are living with that disease. And Parkinson's disease is one of them. So our primary health care level was basically devoid of care for non-communicable diseases. But what we think we should do is this, and which is some of the steps that we have taken. We need to have a policy around that ensures that, what we have done in the past, that we left the care for diseases like Parkinson's disease to specialists in the tertiary level of care or secondary level of care. We need to take it down to the primary health care level and to the community. Of course, at the community level, you talk about awareness creation. Of course, awareness creation and all that, because they need to know about the disease so that when they see the symptoms, they can, report early to the health facility. And you know that in every community you have PHCs. So it is expected, because it is deliberately done like that so that it is the closest healthcare facility to our people where you can easily go to, report, and then they check you. And then, even if you have already developed the disease, we can slow down the progression of the disease. And if you have not and you are at risk, we can actually prevent you from developing that disease over a long period of time. So, and I think with the policy that we've had in place, we've had a policy on tax shifting and tax sharing. That is to say that those tasks that are done at the higher level, we need to take it back to the primary health care level. We need to give them that power. Let us allow them to do some of these things for us, help us identify these cases early, and send them up for us so that we intervene. Thank you very much.
Thank you very much, Dr. Alayo. I kind of resonate with when you said it is important for us, and just like Dr. Mrs. Adedune has said, that looking through the primary healthcare community level, raising awareness and ensuring that, information is cascaded upward, and that is very, useful. And that's why we have a lot of people from the primary healthcare here. So I'll come to you, sir, Dr. Many people, so with your experience and what you have done in the primary healthcare board, how do you think, we can navigate raising awareness within the community healthcare practitioners and some of the people within the local governments, so that early diagnosis, early detection, and proper referral is done?
Thank you very much. Good afternoon, everyone. So the primary healthcare, let me first start by commending ADPF for this symposium, and particularly also for this topic. It's critical that the primary healthcare system is integrated into the management of people living with Parkinson's disease. Primary healthcare primarily is the first point of care. It resides at the community grassroots level. It's a healthcare managed by the local government, with other levels of government also being stakeholders, the local, state, and the tertiary, including the community. And then that makes it very important, because it is the individual and the family that experience and go through, this journey for someone who lives with Parkinson's. So to answer your question, the first thing is community awareness, which has been established by other panelists. But what I would add is that why primary healthcare is critical is that you already have a structure that exists. So we're not designing something new. We're just integrating this particular disorder or disease into the system to ensure that we're able to first detect early, we're able to counsel both the individual affected, caregivers, and others who are also affected directly or indirectly by that individual. And then we're also able to escalate and move that individual to a higher center, so that person can then get specialized care. So the first thing really is community awareness. You have World Health committees within every local government, within every ward in a local government, particularly, for example, in Lagos State. World Health Committee members are people who reside in the wards and who have a deep interest in the health care of their people within their locality. These are the people that act as a bridge between the primary health care center or the primary health care workers and the community. So if we're able to engage them, we have, for example, health education officers, community health workers who work within the primary healthcare system. The primary healthcare system has a large number of various cadres that work in that system. We will have different responsibilities. So if we are able to engage these health workers by, as Prof had said earlier, capacity building, I'm happy to hear that has started, but I think it needs to be also intensified. If you are able to build capacity of health workers at that level, maybe by producing checklists, operating procedures, things that they can see and identify to help them get the patient as early as possible. And then the same people have a link with the community, whereby they engage the community and inform the community about this emerging, if I could call it that, emerging disease within our environment. So that there is an understanding between the community and also at the primary healthcare level. Once we have that structure, at the primary healthcare level, we don't work in isolation as well. We have various healthcare workers. In Lagos State, for example, you have doctors that work in primary healthcare centers amongst other healthcare cadres. And just as the panelists have said that, you also manage not just communicable diseases, but also non-communicable diseases like hypertension, diabetes. So Parkinson's would then fall into that structure, whereby you have then identified the patient through that checklist or through our understanding as health workers. And then we create, there's a referral pathway that needs to continually be strengthened so that, at that level, you can then refer through by communicating with the higher centers, secondary centers, tertiary centers, where you have neurologists who can then manage the patients, at that level. And then the last part is that because it's a two-way referral, these people will go back to their communities. Absolutely. And they need continuous, management. And so when you get back to the primary healthcare, you then go back to your primary healthcare center. Because that healthcare worker is also trained, you are able to follow up, on the patients. That is on a basic level, drug adherence, amongst, other things. So I think that's what I do think.
Thank you very much.
I think that's what I want to add on that.
Thank you very much. Please, if you want to clap, please, let's clap for him. And one thing that resonated with me is continuous strengthening of the referral system. Because it's not like it's not there, it's there, but just strengthening it, through awareness, and the awareness going up, and, going up and coming down. Thank you very much for that. I will come to Professor Frondofar, Professor Marcus Frondofar, and I will draw a, drawing from your work on global health governance. What practical lesson can African countries, or Nigeria in particular, adopt to integrate Parkinson's care into primary and community healthcare system? Prof, thank you. Please, media, can you unmute, ask him to unmute. All right, while we wait for Professor Marcos Frondofar, let me come to you, Dr. Alayo Shukweton. I know that you work at Federal Ministry of Health, and you deal basically with policy, and I understand that You've mentioned something about policy. Not like some of these policies are not there, but how do you think we can strengthen this policy and ensure that the policies are cascaded down to the primary health care system, and and we can action on these policies? Thank you.
Thank you so much. I think if I understand you, maybe the question should be, these policies, how do we implement it, or how do they translate to actions?
Actions,
maybe at the lower level of care. Yes. Of course, for instance, the national policy on the prevention and control of non-communicable diseases, we have it, a national policy, okay? And then, normally when we at national level, remember, it is the federal government that produces policies for health for the country. And what we do normally is that when the policy is done, we take it to the National Council on Health, and once it is approved, that's to say all the states ratified it, and it is expected that the state now adopt or you adapt it, to your state or to your situation. Then, of course, we also have the policy I mentioned that time, tax shifting, tax sharing policy, which was also approved by the National Council on Health, and it is expected that states will implement it at the state level. But of course, beside that, we don't just do the policy and then we go back and relax. We actually support states, every state, to implement. But it depends on what is the priority for the state. For instance, I had Professor Njideka talking about what has been done across the country. Yes, of course, right from medical school, we know about Parkinson's disease and all those things that are associated with it. And then maybe during the practice, you see just few cases, okay? But, you know, when I now left hospital and moved to the ministry, nobody talks about Parkinson's disease. You understand? Maybe everything is just being discussed at the clinical level, but, you know, at policy level and at, for us, public health level, because it's a public health issue, that is to say, it is something that we need to identify very early. And before we can do that, because for government to now prioritize that and say, okay, we need to pay, that is to say we need data, we need epidemiological data, which is what she mentioned that time. So once you don't have that, government will not prioritize it because, you know, we have a lot of things that are competing for these resources. And the thing is that the resources you have, you want to spread it far, you know, to cover a lot of things. But once you have that data to support what you are talking about, and then we can build a policy around it, and then we have a guideline, we can develop all those things, SOPs, protocols, and all, you know, for these people at the lower level, for them to know what to do, particularly in identifying early, in reducing the progression of the disease, and all that. So now, to come back to your question, how do you make sure that, okay, the policies are implemented? The first thing is that, not that the policies are not there, is for the state to adopt or adapt, and then, because every policies come with strategic plan of action, how you do it and what you are going to do, what you are expected to do. But of course, that is also, like I said, depends on the peculiarity of your state. For instance, he mentioned that in PHCs here in Lagos State, they have doctors, they have medical officers, but that is not the same in the northern part of Nigeria. So you may not even, in fact, even in general hospitals in many places in northern part, you may not find a medical doctor. So, but will you now say people should not receive care? No. And that is why we have that tax shifting and tax sharing policy, so that other allied healthcare workers, we can train them, build their capacity, there are basic things they can do, and then the remaining care workers who are at the top can actually help. And then he talked about two-way referral system, because these people, after you see them, they will go back to their community. You have to strengthen that system to make sure that, yes, when they receive care at the higher level, they go back to their community level. Those are the lowest level, which is the PHC, can provide certain level of care. So I think the resources to do things that cannot become, because it is very cheaper, you know, it's cheaper to prevent and to identify early, so that when I watched your what was that? Your
documentary.
Yes. Yeah. So I mean, I saw people that a lady, I think she said she started something. There is one that she said she is 40 or so. You know, it's painful because, you know, the productivity, the contribution to the economy and all those things, because you need to link health with economic development of a country. So, and you see that once you have that, of course, you've lost that person. So, and once we can do that, the state should also prioritize, you know, all these diseases that we have prioritized at national level to say, okay, these are the diseases that have been, particularly non-communicable diseases that have been prioritized for the country. They need to prioritize them, and then we can provide all the necessary support that is needed, be it technical support or right, otherwise. Thank you very much.
Thank you very much, sir. Please, so tax shifting, tax sharing, you know, and I'm glad that, you know, the Adele Medisalo Parkinson's Foundation is putting this together, bringing these critical stakeholders to discuss this, because this conversation is not ending here. It's just to create an action that would last longer and that would bring a positive change that can be actioned, actually. So do we have Professor Marcos Frondafa online?
Yeah, can you hear? Can you hear?
Yes, we can hear you. Please go ahead. Thank you.
Okay, thank you very much. Thank you very much for inviting me. And hello to the panelists and Julia. I'm not out because I'm not an expert on Parkinson's disease. But one last few years is analyzing politics of neglected diseases. And what's true when listening to all the talks and documentaries, the trailers and discussions so far is that Parkinson's disease in Nigeria and other countries shares lots of the central characteristics of neglected diseases. For example, patient populations are neglected, particularly in rural areas. There is political neglect from the government ministry, and also neglect on the part of the pharmaceutical industry. They're lacking resources, lacking capacity building. Diagnosis is very often delayed, and in addition, there is very often lacking awareness and knowledge, both among society at large and the medical community as well. And in addition, there's also lots of stigma involved. So lots of people don't know, family members, for example, don't know how to deal with the disease, of their loved ones, So, and all those patients that are affected by neglected diseases very much share the same characteristics. So I'd like to give you one example, and that refers to visceral leishmaniasis. So visceral leishmaniasis is one of the most neglected diseases in the world. It is endemic across the global south, Latin America, all over Africa and Asia, and also in Nigeria. It's also endemic in Nigeria. And the hotspot nowadays, the global hotspot for visceral leishmaniasis is Eastern Africa, so particularly Kenya, Uganda, Ethiopia, and Sudan. So visceral leishmaniasis is unlike Parkinson's disease. It's a parasitic disease, so transmitted by a parasite, and it's highly infectious, and you need treatment, otherwise you die. It affects your inner organs. So around 20 years ago, there was no real focus, no real research or care or treatment of visceral leishmaniasis across the world. Only in 2007 did the WHO adopt the very first resolution on leishmaniasis control. So that's only 20 years ago, even though visceral leishmaniasis has been known to the medical community for more than a century. So again, up to 10, 15 years ago, you had similar problems that I've heard with regard to Parkinson's disease: lack of data, lack of monitoring and patient numbers, lack of research coordination. So 20 years ago, health activists from Europe and also from African and Latin American countries set up an organization called the Drugs for Neglected Diseases Initiative, short DNDI, with the objective to develop new treatments for, well, a range of neglected diseases. Because as with Parkinson's disease, for many patients affected by neglected diseases, those treatments that existed 15 to 20 years ago, either they were extremely toxic, outdated from the 1950s, 1960s, didn't work, or if treatment existed, they were so expensive that most patients did not have access. And this is also very similar to Parkinson's disease treatment and those treatments and drugs in Africa and Latin America and lots of Asian countries. So DNDI was created, and the interesting thing about DNDI is that it's based in Geneva. It was created by European healthcare activists, but in close collaboration with local research institutes from endemic countries, so in Latin America, in Africa, and in Asia. And one of the central founding actors of DNDI in Africa is the Kenya Medical Research Institute, short KEMRI, because Kenya is one of the endemic countries for visceral leishmaniasis. So then, after its creation in 2003 and 4, DNDI worked together with KEMRI and other leishmaniasis research institutes in Africa to screen and scan the environment to see, well, what kind of capacity exists on leishmaniasis. is there any capacity at all? Because no one knew. And they found out that yes, research capacity and care and treatment capacity did exist in lots of African countries, particularly the West African countries, Kenya, Uganda, Ethiopia, and Sudan. The problem was, however, that most of these institutions and specialists didn't know of each other. So they didn't collaborate, they did not coordinate, they worked very much in silos. As also was mentioned earlier on by one of the keynote, that is one of the key challenges, overcoming these silos. So then DNDi, in close cooperation with KEMRI and universities in these Eastern African countries, what they did was develop a platform, a research and treatment platform, bring those different universities, research institutes, and specialists together to create a common community, East African community with shared interests and common goals to tackle leishmaniasis together and to instill the idea that you are not alone. And even more, that leishmaniasis is not necessarily a Kenyan problem, a Ugandan problem, or a Sudanese problem. No, it's an African problem. It's a regional problem. It's a problem that affects all of us. And as a consequence, all of us need to work together. So over time, this platform and this close cooperation created a new identity that didn't exist before, a regional identity, and putting those African technicians, leishmaniasis specialists and experts in the driving seat. So they became the proactive actors supported by DNDi to develop new treatment and new care for leishmaniasis. And as a consequence of that, these organizations built new treatment centers in those rural areas, particular rural areas where leishmaniasis is endemic, so far away from the big cities and the capital where you usually have access to treatment, while in the rural areas that's not the case. So they shifted treatment and care to those rural areas where patients live. So in other words, they brought the research, the treatment, and the care to those neglected patients in rural areas, in villages, far away from the major city. Yeah, and by doing that, they trained nurses and technicians so that high quality care is provided to those patients living far away in remote areas in those countries.
Absolutely.
Does that answer the question?
Thank you very much, Professor, for that. We need to collaborate in every sector. And you know, something I would like to bring to the list here. I'll come to Dr. Adeduni. First and foremost, how do we actually collaborate, and who are the people we collaborate with? Because if we are not collaborating, we are not getting anything done. And if we just narrow it down to only the health sector, like for instance, if Adeomi Desalu Parkinson's Foundation is not putting this together, how are we going to bring Dr. Supeton from Federal Ministry of Health, bring Dr. Sushaya from, and bring everybody together? So how can we get this sorted going forward? Because like I said, to action everything. This is not ending here. We are moving it forward and making sure that we have something to relate with as we care for the Parkinson's ecosystem. Thank you.
Thank you very much. Thank you for the question. Well, I think we've answered the question. Collaboration, that is what we are doing here. Different people from the community, stakeholders, people who are affected by PD, health workers, policymakers, we are all here talking about this today. So I'm sure going forward, we'll continue with this. Now, collaboration is not something new. I could talk about, so something is being done in the African setting. I met a neurologist from Kenya some time ago, and it went on and on about Prof. Okubadejo, how she's been awesome. So I was wondering, she lives in Nigeria. How did you get to know her? So they are relatively new when it comes to Parkinson's disease movement disorder. And he told me they actually have a way of reaching out to her, and she'll guide them through the diagnosis on how to do things. So we have someone who is at the forefront of that. And it's not just for doctors. We have affiliation with pharmacists, nurses, physiotherapists. So it's just bringing everybody together under the same umbrella. We can do it by organizing meeting. The digital platform is excellent. WhatsApp group. We could have, we're talking about the state settings. We could actually fragment the states into different segments. I know we did some form of, not related to PD, but dementia. We had health workers, primary care workers, health educator, come for a seminar and a workshop. We fragmented them, trained them on the process, and we had a feedback mechanism. So that can be done, and that can be further developed by providing digital platform to be able to follow this through. Thank you
very much. Thank you. I'm sure we have people from all the local governments in Lagos State, both from the Medical Officer of Health, ward committee members represented here, because we actually reached out to them while planning this event, because we wanted to integrate every arm of the primary health care. And we want everybody to be aware. So it's not just something that is tertiary or secondary health alone. And I'm glad you mentioned the fact that, you've done something similar, and this is what we also tend to do. Let me come to you, sir. Based on your experience, because you are more or less like the arm that oversees the primary health care itself. And going by all the challenges that is currently facing the Parkinson's ecosystem. Dr. Shupet mentioned that there is data, data will inform policy. And how do we even harness the grassroots workforce to get the data? Because I believe, from my own experience with the Parkinson's community, a whole lot of people have Parkinson's, but they don't know it is Parkinson's. And how can they know if there is nobody telling them? And how can this be done if we don't have people within the community that is going around? So how can that be? How can we even strengthen that community workforce to ensure we achieve the best?
Yeah, thank you. Thank you very much. So just as you have alluded to, it's a continuous effort. I think this is the foundational part of that effort. We've spoken about the importance of, bringing in healthcare workers at the primary healthcare level on board in terms of capacity building.
Absolutely.
And then a follow-up with supportive supervisions and the likes. Apart from these workers who work in the facilities as well, you also have, and let me mention that at the facility primary healthcare level, you have health information managers or officers who capture data at the facility level. And I'll give an example. Non-communicable diseases registers, hypertension, the common ones, hypertension, diabetes. These people in the communities are captured within the facility register. So what we're now saying, which was what I said earlier, is like integrating also, for example, the Parkinson's disease. Yeah. I think what just needs to be done is intensifying our efforts.
Absolutely.
In doing that and ringing the bell on Parkinson's disease. In fact, when the permanent secretary of the board requested that I stand in for him because he had to be somewhere this morning, I was, I was happy to have, because I had to, I was telling my wife, I had to go through the Parkinson's disease and, identify some things that have been done. And then I realized that it's actually important that the primary healthcare system is also more integrated even further, in its management. At the community in capturing data, we have community volunteers. You have community health workers who usually go into the communities to see patients, manage patients. They do surveillance as well. So you have community volunteers who are like surveillance officers or surveillance persons, focal persons, who listen, get information from the community. Now, it's not theoretical. Absolutely. This is what happens at the community level.
At the grassroots level.
At the grassroots level. Yeah. You have them. Yeah. And what we just need to, it's not perfect, but it is there. And we need to just keep strengthening, that system. So if these sets of people are also sensitized and their capacity is built, likewise, like we had said, the community, like I said, you have World Health Committee members who have people who have interests in the health of their community. They comprise of a key influential leader. They comprise of women groups, youths, and the likes. So if we can identify these people, what happens is that the community reports to the primary healthcare level. The primary healthcare level captures that data, right? And that data doesn't stay at the primary care level. At the primary healthcare centers, you report, on a monthly basis, for example, to the secondary level facility. So to the Lagos State Primary Healthcare Board, to the State Ministry of Health, who also reports again to the Federal Ministry, National Primary Healthcare Development Agency. So I think it's about strengthening and taking deep interest of identifying these sets of these people who live with Parkinson's and integrating them at that level, while we also, work in collaboration with the specialists at whether the secondary or the tertiary facility.
Thank you very much. Please, one thing I want to say is that we all that we're here, we are advocates, aside from the fact that we have people with Parkinson's. And it is important for us to go back and keep spreading the word, because a whole lot of people, population, don't even know that, this thing is there. I would just want to ask one question, because this particular question is part of the thing that many people with Parkinson's are facing. So I will start from Professor Frondofa. Sorry, I apologize for mispronouncing the name. You wrote something in your book that has to do with physical knowledge common for neglected population. And from your perspective, how can this concept help address the gap in accessing of Parkinson's medication and treatment in Nigeria and the middle income countries? So, Prof, can you just address that
Of
quickly?
course.
Thank you.
Thank you very much. I think that very much so, the idea of common.
Please, can we unmute Prof?
Can you hear me?
Okay.
Yeah, can you hear me? Can you hear me?
All right, please go ahead. Quickly,
Okay.
please. Thank you.
Thank you.
In summary,
Thank you.
yeah.
So the idea of the common very much connect to what has been mentioned by the one keynote speaker. There is no need to reinvent and partnerships are key. So the organization mentioned the Drugs for Neglected Initiative, or short DNI. What they did across the world in collaboration with local universities, research institutes, patient associations on a range of neglected diseases is build new partnerships. particularly local partnerships, partnerships that are anchored in the local communities and the countries of that are endemic for neglected diseases. So these are platforms, transnational platforms across countries, so not only within countries, but across countries, entire world regions, for example, on leishmaniasis, Eastern Africa, which connected all these different institutions, experts, in a regional transnational approach to leishmaniasis or other diseases. Yeah? And I think this approach may also be very useful for Parkinson's disease because, again, it's a global disease. It's a disease that affects people in Nigeria, but across the entire continent. And yeah, there is Parkinson's Africa, for example, as a transnational organization. So I think all the key elements are already there. The principal ingredients are already there. But as the previous panel member has said, all those efforts need to be strengthened. They need to be reinforced to build a transnational approach, an international approach, a transnational pan-African community to Parkinson's disease, because that would strengthen and reinforce not only the Adewunmi Desalu Parkinson's Foundation within Nigeria, within Lagos, but across Africa, and connecting to other institutions that do similarly inspiring work. So developing a cross-national, a transnational, regional African approach that could then, as a next step, connect to similar models, similar networks in other world regions, such as Latin America and Asian countries, in order to share knowledge, share expertise, and share ideas, and also, more importantly, financial resources in order to promote research and development in finding new treatments, reinforcing care and treatment.
Thank you very much, Prof. Please, can we put our hands together for Professor Frandafa? One thing we have to, as we bring it to a close, one thing we have to take out of this is the fact that we need multi-stakeholder kind of integration into the care ecosystem. So if you have any question, we can just give room for just 2 questions for our panelists. 2 questions, please, because our time is gone. 2 questions, please. If you have questions, please, I need somebody to bring the mic, please. One of the volunteers, please. Can you bring the mic, please? Please, 2 questions, then we'll wrap up. So please, while we have, that, just your final kind of thoughts, because in this room we have different people, and what you want them to take as a take-home from this. So please, I need the microphone to be sent to. Okay. Technical team, microphone, please. Hey, please. Somebody's. All right. Thank you. Please go ahead.
Okay. Hi. Good morning, everyone. A pleasure to be here. My name is Osahon, representing St. Joseph's Physiotherapy Clinics. I'm very passionate about Parkinson's altogether. I've had over 16 years of practice. And especially in the case of falls, someone asked a question about falls earlier, because we are pretty much in patients' homes and see the risks, see the high risk of their falls. And as regards, I like the idea of the phrase that was used earlier, the Parkinson's ecosystem, because I think it takes a lot of collaboration, as we've repeated here in the care systems. Dr. Olusoyan said something of that sort. And when you go to patients' homes, we tend to see the risks they are exposed to that no one talks about, no one sees. It's in the lighting, it's in the tripwires, it's in the design. The collaboration is really big because I've had to speak to even electricians, positioning where the sockets are, where the plumbing is, the sinks. All these kind of things tend to raise the risk of their falls. And then I don't know how that can filter down, not just to health workers, the community, but even design. Like we said, it's broader than that. The design of their homes, designs of their bathrooms, their rooms, and everything that can increase safety and reduce falls. Thank you.
So, thank you very much. Dr. Olusoya, can you respond to that? Oh, okay. You want to? All right, go ahead. Thank you. Okay.
So actually, thank you very much for the contribution. I see that as a contribution and comment rather than a question. I think this question or this contribution, or we are being challenged to build a network. So we'll work collaboratively, maybe after this meeting, and see what can be done. But I'm sure something big can come out of this. Thank you.
Absolutely. Thank you very much. All right. Any other person with question? All right. Okay. Thank you.
Thank you for the panel discussion. I'm Dr. Eta Aripo, Deputy Director, Ministry of Defense. My question is on when the policy is generated, what happens? Because PD is cost intensive. Who bears the cost, the sufferer or the government? Last month I attended an IBRO-sponsored event in Ogbomosho, and the radiologist told us of several investigations, over 5 investigations running from CT scan, MRR, functional CT, SPECT, machine learning, to make a diagnosis that will help stem the progression of the disease for over 5 to 10 years, because it's a progressive, non-reversible degenerative disease. So the patient motor disability will actually end in loss of motor functions and all the complications that go with it. So my question is the government willing, or will they in their policy be able to carry out the cost of these investigations? Thank you.
All right. Thank you very much, sir. Okay. Prof. Okay. Prof wants to respond to that. Please bring the microphone to Prof. Please put your hands. That's a very awesome question. Yeah.
So thank you very much for that question. First thing I want to disabuse our minds of is that the diagnosis of Parkinson's disease is largely clinical. You do not need any of those investigations. Occasionally, they will be required where there is a doubt as to what the exact cause is. But that is the exception rather than the rule. I think that setting was more intellectual than it is practical. Secondly, the short answer to that is health insurance. We need to fix the national health insurance system and ensure that the things that it covers includes things that are pertinent, and I say pertinent, to the diagnosis of Parkinson's. So basic investigations, if and when required, but more important, physical therapy and other therapies that are required. If we make the mistake of having insurance and allowing that insurance to start covering things like you mentioned, PET scan and so on, we will be wasting resources that can be used to address the needs, the real needs of people with Parkinson's.
Thank you very much, Prof. Dr.
Yeah, thank you, Prof. In addition to what she said, and for me, I think we should have a holistic approach to all the things that we have discussed here this morning. And how do we do that? First thing first, one, let us all agree that we need to prioritize care, treatment and care for Parkinson's disease in our country. That is the first thing. So once we are able to do that, then, like I said, we now have a policy statement around it. We develop a guideline, a holistic guideline that we talk about from identification to what do you call it, either rehabilitation or whatever, and all those things that we've talked about here, and including what you said, that how do you take care of maybe them falling, like somebody talked this morning that how do you prevent that and all those things. I think those things will be discussed in the guideline and all those things. And I'm now going to challenge the Salo Foundation at this point. Now, Njideka is there. Let her provide all the necessary information that we needed. Forward it to the Ministry of Health and let us do something about this. Thank you so much.
Thank you so much, sir. Thank you. That's one of the outcomes for this event, and I've achieved it. I'm glad. So, just the final, your final, what's it called? Thoughts, and recall it.
Yeah. So, it's again, I think it's intersectoral collaboration, government, NGOs, development partners, foundations, and the likes working together and ensuring that, you know, just as the panelists have said, that there's a continuation, which is the more important part. For myself, who have come here and represented the Lagos State Primary Healthcare Board, I want to assure the symposium, the meeting, that I'll be taking this message back to the Lagos State Primary Healthcare Board so that we can follow up with it and partner with other partners in ensuring that we prioritize Parkinson's disease. Thank you.
Thank you very much, and that will bring us to the end of this panel session. We would like to thank you. Prof. Fanda, can you just give us one more word before you go, before we call it a day? Praise. Okay. All right. Thank you very much, everyone. Thank you very much, Professor Marcos. We really appreciate your time. Dr. Shukpekon, we thank you. With Dr. Osusonya, we thank you. And Dr. Olusonya, we really appreciate you in absentia. She needed to take a quick break. Thank you very much. Please, let's put our hands together. Okay, we are supposed to have a group photograph on stage. All right, let's just do the group photograph. So while we do that, we've been sitting for a while, and part of the activities we have at the foundation is dance therapy, and we want you to have a little bit of what we do at Adewumi Salo Parkinson's Foundation. So please, I would like to call on our dance coach while we have this group photograph. Let's have the stretches, a few minutes stretches before we move to panel 2 session. Thank you very much for your time and your patience. We really appreciate everybody. Thank you, our panelists. We really appreciate you for your time. Please, our dance coach. So this is just hey. So can we please can we just rise? Can I ask us, please, can we rise up? Everybody, please rise up. It's just stretches. We've been sitting for an hour and we need to stretch our bodies. All right.
respect I give my mama. You say make I give you picky, make I give you jelly jelly. Sissy, you're beautiful from head to toe. Sissy, you're beautiful from head to toe.
Good morning. Please let's we're taking it side to side. And steady. Side to side. Let's go. Side to side. Alright, your arms. Arms. Let's go. Open up.
You got a pretty face shot.
4.
You got a pretty body shot.
3.
But then you never gonna allow me touch.
1.
You way too free.
Alright, take it back. Hands on your waist. Look up. Look up. Take it back. 3, 2, 1. Take it up slowly. Now cross up.
Give you the key to the new key. I know I'm trouble you. I know I'm trouble you.
9, 8, 7, 6, 5, 4, 3, 2, 1. Take it up.
You're beautiful from head to toe.
4, 3, 2, 1. Heads to the side. 3, 2, 1. 3, 2, 1. Now take it up. 3, 2, 1. Take it down. 3, 2, and 1. All right, let's go.
Feeds.com.
DJ, can you please increase the volume, please? The volume, please. All right, so we're stepping to the side. Slow and steady. To the right now. Let's go together. 1. That's it. Now, on the way. Let's go. Easy. Forward now. Step forward. Take it back. Let's go. That's it. Now.
What you want my toto? I need to be girl like you get Fuji. Odupa, Olua, Olua, yeah. Joy is coming, joy is coming. Dupa, Olua, Olua, yeah. Joy is coming. Only early in the morning. Odupa, Olua, Olua, yeah. Joy is coming, joy is coming. Dupa, Olua, Olua, yeah. Joy is coming. Only early in the morning. Let's go. Open never. Do what you wanna do. I want to be shining all day. Yeah. Don't make that, don't make tender. I want to
take it back.
I want to look for the one day. Yeah. It's in a meeting, take it easy. Catch this on cruise for my cheese. You spoke one for days. Come on for the body, know the breathe. Put on your shoe, make it stand that tease. All your sorrow, make it dance them free. If you know, look la yeah. If you know, be la one man jogo, ijogo, what you want, my jojo? Ijogo, when you my jogo, and if you know, be like the food. Odupa, Olua, yeah. Joy is coming, joy is coming. Dupa, Olua, yeah. Joy is coming, only early in the morning. Dupa, Olua, yeah. Joy is coming, joy is coming. Dupa, Olua, yeah. Joy is coming, only early in the morning. Yeah.
More music on trendybeats.com.
We still have one more. We still have one more. So we step to the side. 1, 2. All right, let's go. Right leg, step back. Now. Step. 3, 2, let me go.
Dear Father in heaven, about time to take over. You don't tell I trouble you. Back down to Lucifer. I not to follow pastor, they be for mom. Father na father. See me, I don't busy my call. I won't focus on you, who's on God. I only fanny to my way. Any to my way. You go home, no more cannabis. I only fanny to my way. Any to my way. You go home, no more. Me, I get sense, I get God. I come first, I don't boss. Plenty talk, plenty noise, plenty people don't call me, but me I get sense, I get good. I come first, I don't boss. Plenty talk, plenty noise, plenty people don't call me, but hey God, don't make I follow. This one waiting stay cause I still want to ball, I still want to turn on. Hey God, don't make I follow. This one waiting stay cause I still want to ball, I still want to turn on. Dear Father in heaven, sometimes I catch your blessing. He did take to show for face. He be like the HIV. Churchy for club, kitchen for club, landy for photo. Make them know mommy and I only fanny to my way. Any to my way. She won't know my cannabis. I don't boss, plenty talk, plenty noise, plenty people don't call me, but me I get sense, I get good, I come first, I don't boss, plenty talk, plenty noise, plenty people don't call me, but hey God, don't make I follow. This one waiting stay cause I still want to ball, I still want to turn on. Hey God, don't make I follow. This one waiting stay cause I still want to ball.
All right, thank you very much. Thank you very much.
I only fanny to my way. I only fanny to my way.
All right, thank you very much. Now you have taken part in one of the things that we do at the Adeomi Desalu Parkinson Center. So you know that it's fun to exercise. If you go to the center, if you see all the things that we do through our impact, you see that dance therapy is one of the things that we engage in, and it helps the Parkinson's community. While we were having the panel session, we had the representative of the Commissioner of Police, Dr. Salami, walk into the hall. Wherever you are, Ma, please can you, please put your hands together for her. She's representing the Commissioner of Police, Lagos State. Thank you very much for honoring our invitation. So we'll be having resilient message. And that resilient message is going to be taken by Professor Kimberlin Campanello. Professor Kimberlin is a professor of poet from the University of Leeds. She was diagnosed with early onset Parkinson's, and she will be sharing her resilience story with us. Please, I would like us to pay attention and let's learn and most especially from the Parkinson's community, there is one or two things for us to gain message. Thank you very much. Can we have Professor Kimberly Campanello? Thank you.
Hi there. I hope everybody can hear me okay. I'm thrilled today. I had a wonderful time dancing just now. It was exactly what I needed because I was feeling a bit stiff. It's the low point in the medication dosing, and I thought, wow, this couldn't have come at a better time. And there was so much joy in the room, and it just boosted me just to no end. So thank you to John and to everybody from the ADPF. It's my second time speaking, and I'm always just blown away by how thoughtful everyone is in this context, but also how much it's developed even since last year, how much the conversation has moved forward and the ways in which everyone's coming together and talking. It gives me so much hope around just, not only Parkinson's, but the possibilities for people to come together and make positive change and positive connections. So one of the things that John asked me to talk about was, a message to people who've been diagnosed and to family members of those people and friends of those people. And what I would say, because I'm now 5 years into my diagnosis, I was diagnosed in 2021 at the age of 41, and I'm about to turn 46 in July. And so I think the key insight that I would have, looking back over the past 5 years is that Parkinson's is hard. It's very difficult. Nobody would say, oh, I really want to have Parkinson's. But I would say that there's been research that talks about the silver linings of Parkinson's, the silver linings that people with Parkinson's often describe. Because what this illness can do, actually, I think, is make you get to the essence of things. It makes you focus on the things that are most important to you because your energies work in a different way. And you also have to fit in lots of other things. You have to think about exercise. You have to think about stress levels and how to keep them low. It kind of puts you in a situation where you can embrace those things that are most important, and it's crucial that you do. And sometimes those things are advocating for others, and sometimes those things are advocating for yourself and making sure that your own voice is heard and that all the information that you have is valuable. And I think that that's what this space is creating all the time, is the sense that in some ways people with Parkinson's are inherently researchers. We're inherently doing the grand experiment ourselves of trying to figure out how to live. And they say that Parkinson's is the designer disease, that it's different for every person, which is absolutely true. But we can and do talk to each other, and we can notice things that could be useful for research, but could also be useful in day to day. And so that would be my other point, which is whether you get involved formally in research or formally in advocacy, I think it's really important to give yourself a pat on the back, stretch out your scapular muscles, but also to recognize that you're living throughout a day in which things are changing all the time. Your fluctuations may be changing, or you may be in a position where getting medication is difficult and you wish you had fluctuations. So the fluctuations that we get from, levodopa treatment is a privilege. And I think that there's that point as well, which is, we can recognize that not everybody's experience of Parkinson's is the same. And that's where these sorts of spaces to come together are really important. I also think, I could be saying this in a kind of prideful way, but I do think some of the best people have Parkinson's. So everyone I've met who has Parkinson's or who works with people who have Parkinson's or who surrounds those people, they're just the best people. I just feel like it is again a privilege to be around and a part of the community. And it's another one of those silver linings that gives us insights not just into how to work with Parkinson's and how to deal with this problem, but actually how to be human. And if we can't, solve every problem, actually, if in some ways we come together and on a very small level, transform a few seconds of someone's life just as a result of those insights, I think that's quite a big deal. I also wanted to just mention some of the things that I would suggest that you do. and I'm sure you're already doing it, which is to do things that you never thought you would do. You know, I never thought I would be dancing with all of you on a Saturday morning on April 11th, you know, and I just did. So Parkinson's can take you into strange corners of experience that can be embraced, I think, and it ties back into that idea of valuing your own insights from your experience and for family members to listen to those insights and to help that person keep track of them. Because I think that's the thing is we're always thinking about how this is mapping. And that's one of the big questions is, you know, in terms of medications and other treatments, optimizing those for people within the limitations of whatever the circumstance might be. And that's where having that information is really important on an individual basis. And it can be taxing to gather that all the time because you're, you know, I say you're a researcher, but you're also experiencing the thing you're researching. So I think for me, that's what I've gained in the past 5 years is a real perspective on the value of listening to other people with Parkinson's, but also to the fact that spaces like this one are increasingly bringing our voices in and in a way that allows us, I think, to tip off potential avenues for research that may get at the heart of some of the causes, but also some of the mechanisms by which medications or other treatments could be effective. So I will pop a few links into the chat. I've gone down a rabbit hole around multilingualism and Parkinson's, and I do think that there's something that's being activated in the brains of multilingual people in the ways in which that might be exploited in terms of treatment targets. And so I've been in contact with a lot of neuroscientists about this. I am not myself scientific enough to do the research, but it's from my perspective as a person with Parkinson's who's a kind of a researcher and who's hoping to build those conversations like the ones that have been built today. So thank you so much for having me around and thank you for the dancing. I loved it.
Thank you so much, Professor Kimberly Campanello. That's a huge one. Diagnosed with early onset Parkinson's and still actively engaging in her professorial work actively in Leeds. So while we're having the session, we have somebody that came into the room. I would just like to introduce her. We have Mrs. Joke Silva in the list. All right, okay. All right,
she's left. She was here from the beginning.
Okay, she's all right then. Thank you very much. We really appreciate her. And for the panel too, and now you know it's getting more heavy. I'll put it that way because we are diving down, we are diving deep now. And this panel session is building resilient Parkinson's care ecosystem through and partnerships and sustainable support system. So our chair, Board of Trustees, will be anchoring this session, Mrs. Maureen Desalu. So she's going to call the panelists for this session, please. So go ahead.
Thank you. So for those who are tired, don't worry, this is a quick one. We know the time is fast spent. I'm going to start by introducing online Miss Ota Ahigbe. Is she there? Media, can you please spotlight Miss Ota Ahigbe? She's in Abuja and she's online. I'm going to invite Dr. Olugbenga Fadikbe, who heads Ilera Eco, which is a health insurance scheme. And he's representing Dr. Emanuela Zamba, who is the permanent secretary for the Lagos State Health Management Board. A round of applause to encourage him as he comes up. Thank you, Dr. Fadikbe. Please come to my left. Thank you. And the last person who is joining us for this conversation is Barrister Ufoma Emore, who is a person with Parkinson's, young, and a powerhouse on his own. He's somebody who started out shy, but has become the poster boy for young onset Parkinson's. Barrister Ufoma Emora. So, thank you, welcome. You have a microphone? You have a microphone? Okay, so our topic is building resilient Parkinson's care ecosystems, workforce, partnerships, and sustainability. Lots of big words. So, what are we going to do? Let's talk about lived experience and system gaps. Is Miss Ahibe online? Yes, we can see her. I'm going to ask you to take this first question. When you think about a person living with Parkinson's in Nigeria, navigating late diagnosis, high treatment costs, and limited support, what are the most important changes the system needs to make to truly support them? Can you take that? Can you unmute her, Ms. Ahibe? She's frozen? Okay, I will have Barrister Emore take us through that. Do you want me to repeat the question, or you're good?
Please repeat the question.
I should repeat the question. When you think about a person living with Parkinson's in Nigeria, navigating late diagnosis, high treatment costs, and limited support, what are the most important changes the system needs to make to truly support them?
Good morning, everybody. Nice to see a lot of people coming here. What needs to change is people should understand that Parkinson's is not a death sentence, because most people that have Parkinson's, they give up on life and they think there's nothing they can do about it. And I want people to know that there are many of us living with Parkinson's. I've had Parkinson's now for 10 years, and I've been living, should I say, okay, but I must tell you, it's 10 exhausting years. It's exhausting, and one thing, I think when people get the diagnosis, they feel there's nothing else they can do. They can't go out, and it's understandable. You have a disease that has no cure, and it will progressively get worse, so it's a lot to take in. So, but then, for me, I think life has to go on. It wasn't easy. I won't say it was easy. I was depressed. In fact, when I was diagnosed with Parkinson's in Nigeria, you know, I didn't believe it, so I traveled out. But when as I walked into the doctor's office, he said, "You have Parkinson's." Because I didn't. I was bending to my left. I was walking out, bending to my left. I was like, he just said I had Parkinson's. And I said, I was so sad. I was walking on the road. I was crying. I was like, having tears in my eyes. I was like, what am I going to do? I'm a young person. My family is young. And what am I going to do? But as if by divine magic, my brother in Canada called me. I said, what's up? He now heard my voice. He now said, what's wrong? I said, they've confirmed that I have Parkinson's. So he said, I said, I feel so miserable. So he said, don't worry. He lives in Canada. 2 days later, he came to meet me in London. And I was like, why do you leave? Because he also has challenge. He said, no, that he wants me to know that no matter what happens, that will be there for me. And I now said, someone drops everything for me. And I said, I should honor him by not being disrespectful, not thinking that he won't. If he could take the disease from me, he would have. Then my wife, she has been so helpful. What I think you need to survive in Parkinson's, you need to have a good support system. If you have a good support system, you can navigate anything. There are times when, because when I got the Parkinson's, I was still working, but because I was working, I was taking too many levodopa, so that I would at least keep up with my work sense. to be able to perform at work. But it was becoming too hard. I was taking more than I should. And I then crashed. So I had to stop work. And the social support system that I have is marvelous.
Thank you. Thank you. A personal story, and I'm going to dissect it. And what I'm taking from it first is that he was in London. Therefore, he got his diagnosis off these shores. So what the system needs to do is to give us that confidence to be able to stay here and get a diagnosis that we respect. Pardon? You got it here before you went there. Okay, then you went to the UK. Okay. Then he's talked about support from his family. And he mentioned that he stopped working. So I'm going to pick on that, which is stigma and sometimes employers discriminating against people who have challenges. Now, apart from this that is neurodegenerative, there's a lot of neurodiverse people in our community with Down syndrome, with ADHD, with autism. These are all human beings that need to live a full life. And our employment system, which includes every single one of us here, discriminates against people with challenges. And it's important that we pay attention to that. And that's all part of what the system, what we can do together to make life better for one another. Now I'm going to ask Dr. Fadigbe to speak.
Okay. Thank you very much for the question. When you're looking at why there is a delay in diagnosis of Parkinson's disease and why we have that situation, more often than not, people don't go to a hospital because of the costs that is, assigned to the treatments and the diagnosis of their conditions. As we know, Parkinson's is a non-communicable disease. As with all communicable diseases, there's really no cure, and treatment is for life. And it costs a lot of money to be able to get the right care at the right place. This is where insurance is important. Well, I'm an insurance person, so it is important that we understand that financial support and clear pathway for care coordination for people with Parkinson's is what is required to ensure that they get the early diagnosis and they're able to follow up with their treatments. And the best way, again, like I mentioned earlier, is for us to do it through insurance. Insurance ensures that there's a financial solution to the delay that you have in getting your appropriate diagnosis in time. Making sure you have access to the specialists, access to physical therapy, access to medication, so that you don't have medication holidays that we always have because of lack of costs. And then people can follow up with their treatment and maintain, their disease control. As we know, Nigeria now has made health insurance mandatory. What we are trying to do with that is ensure that everybody comes into the pool, both people who are ill and people who are healthy. When that happens, the funds and the resources available to take care of a condition like Parkinson's becomes available. Because there's so many competing conditions for resources that are very, very limited. So when you have everybody in a pool involved, the funding available will be significant enough to now start considering, we need to include Parkinson's under coverage. We need to ensure that medications are available, physical therapy is available, access to specialty consultation available. That is the way, and the only way, as far as I'm concerned, that we can deal with it.
Thank you very much. Please clap for him, because that was a very pregnant comment. Incidentally, I have 45 years plus of insurance experience as well. And one thing people would complain about insurance is limits. And in the good old days, pre-existing conditions, whereby people don't actually get registered because they already have some challenge. But I will bring Parkinson's to the table. Is Ilera Eko going to pay 70,000 naira a month for medication? Question one. Question two. Is Ilera Eko going to pay for physiotherapy and not limit what is on offer. Treatment, going to the neurologist quarterly or whatever, I'm sure Ilerico will cover that. But going to the neurologist every quarter without your regular medication is counterproductive. Therefore, I'm just concerned because the cost of our medication is high. Will Ilera Eco? I know it's very good and I know it's for the general public. Therefore, I'm worried about the extent to which it will go. Thank you.
Okay, you see, as with all insurance, so let me start with general insurance. You need to start as you mean to continue. What that means is that if you promise coverage, you must fulfill that coverage. Now, what it means is that sustaining that coverage for the period of time you have an agreement with whoever is under coverage is very important. This is where actuarial analysis come in. The reason we do all these things is just crunching the maths. It's not anything difficult. To see that, okay, if I promise Mr. A that coverage for this condition will be available for 365 days, how will I ensure that that is possible? Because again, funding is important. There's always a financial consequence to healthcare. It is something that we need to deal with. In order to ensure that, you need to have enough resources, which is funds, to ensure that for that period of coverage, that person will have access. Again, I go back to what I said in my first statement. We have said health insurance is now mandatory. Everybody needs to participate in that. When everybody participates, we have more healthier population than people who are ill. What that means is that people will participate, will not utilize the funds. Then the funds becomes available for those who are ill to get the care that they require. Until we get to the threshold of the population where the funding becomes significant enough, we are still going to have hindrances in terms of coverage. It is the reality of the available funding.
So,
and
can I ask, so are you saying people that maybe register, people that are registered on your scheme, the Parkinson will be covered? Or you need the large mass of people?
No, what we're saying is that, okay, I want to just tell him. Now, the way a plan is designed, we look at conditions of public health importance that affects the largest part of the population. So if you're looking at Parkinson's disease, it's significant. There are more significant conditions, really. So you take it, will I say scale of preference now? It is the reality of the funding available. That is why that is happening. So you take it scale of preference. The more funding you have, the more you can cover more conditions. That is just the reality of it. So what we are saying is that currently, insurance covers some aspect of treatment, like specialist consultation. You can see a neurologist. Physiotherapy, physical therapy, for instance, is also covered, but it is limited, okay, because of the available funds. What we are saying, other aspect of treatment, medication, occupational therapy where it's required, speech therapy where it's required, to include that, you will need more resources and more funding to make it happen. Which means everybody needs to participate in insurance for that funding to be available. That is where I'm going.
Thank you. It's recorded, and you may use your phone to take his photograph. And you can call me to be the umpire if there's ever a problem. And I'm very happy that my brother is here. Dr. Adere Midesalu, please stand up to be recognized. This is the chairman of our advisory board at the Adere Midesalu Parkinson's Foundation, who also was permanent secretary health, Lagos State government. So, you are family. We're good. Yes. Okay. We won't drag it, but we thank God. Is Ms. Sahibe online?
Yes, I am. Yes, I am.
Okay. Do you want to add anything to that, or shall I give you the next question?
I think what we've heard so far is actually very important because it brings two things into space very clearly. They've lived the lived experience on one side and the reality of how the system currently responds to it. And I think where the conversation becomes really meaningful is how we connect those two things. Because right now, what we are hearing is that people are navigating a condition that is already difficult. And at the same time, they are navigating a system that is not always designed to support that journey end to end. And for me, that is where the real opportunity sits, not just in improving one part of care, but in making the overall pathway more connected, more predictable, and more supportive. So I think building on what was just shared, I think the most important shift is that we stop designing the system from the point of diagnosis and start designing it from the point where the person first begins to experience change. Because by the time someone gets to a confirmed diagnosis, they have already gone through a long journey, often alone, often uncertain, often unsupported. And the system needs to meet them much earlier in that journey. So I think I would say very quickly, because of time, in practical terms, it means three things for me. The first is earlier recognition, closer to communities. A person should not have to wait until they finally reach a tertiary hospital before someone notices what may be happening. We already have primary healthcare providers, we have community health workers, and we have local care points. The opportunity is to equip them with just enough awareness and guidance to recognize early signs and refer appropriately. And that is something we can start doing within the current system. The second is something that has already been touched on by one of the esteemed panelists, is financial protection. Because even when people get diagnosed, the reality is that ongoing care can be expensive. And it alludes to something that even the distinguished moderator talked about. And chronic care is not real care if it is only available to people who can afford to keep paying for it. So this becomes a question of how conditions like Parkinson's are recognized within existing financial structures, including insurance and subsidy mechanisms, so that care does not collapse at the point of cost. And I think the third and final thing I would say before I cede the floor back is social support and understanding. Because Parkinson's is not only clinical, it affects confidence, it affects mobility, it affects independence in some cases, it affects relationships, mental well-being, and how someone experiences everyday life. And in many communities, it is still misunderstood. So part of the system response has to be awareness, caregiver support, and community level understanding, not just treatment. So for me, the real test of whether the system is working is very simple. Does the person living with Parkinson's feel seen earlier, supported better, and left less alone? Because if that changes, then we know the system is starting to work. And that is the shift I believe we need. Thank you.
Thank you. Thank you. I was going to ask you the next question, but I think you answered it, but I'll ask it anyway. It says workforce and access to care. In a context where specialists are few, how can we realistically ensure that a person with Parkinson's, whether in a rural or urban area, can access the right care at the right time from the right people?
Thank you for that question. I think the first thing we have to do is be honest. A specialist-only model will not carry this burden well enough. There are simply not enough specialists for that to be the whole answer, especially if we are serious about access beyond a few urban centers. And I'm happy that you referenced both urban and the rural areas. So the question is not, how do we wait for enough specialists? I think the question is, how do we design a system where specialist expertise travels farther? And that is where I think the opportunity is. To me, the answer is a more connected care model. A model where specialists remain essential, but they are not the only doorway into care. A model where primary care providers, general practitioners, nurses, physiotherapists, community-based workers, and caregivers all become part of a functioning care ecosystem with clearer roles and better referral pathways. Because what patients need is not just expertise in one location. They need a pathway. They need to know someone can recognize the issue, someone can guide the next step, someone can connect them to the right level of care, and someone stays within reach afterward. That is what makes care feel real. And this is also where digital enablement can be very useful, not as a shiny extra, but as practical infrastructure. So from this perspective, I'm speaking more from the digital enablement. If a frontline provider can capture concerns earlier, if a referral can move faster, if a specialist can advise remotely, if follow-up can be better coordinated, then access improves even before the total number of specialists change. So for me, the real answer is not to stretch specialists thinner. It is to build a smarter system around them, a system where knowledge is shared better, referral works better, and the person living with Parkinson's is not left trying to coordinate the entire journey alone. And this is where digital enablement comes in. And we're seeing some of them in the area of telemedicine and the likes. And that is really how access becomes more realistic from my perspective. Thank you.
Thank you. Very robust response. Thank you. And Professor Kubayadojo, who I can still see in the room, agrees with you entirely, because we've talked about her consulting in other places by being in one place. So digital it is. So that means power and many other things. One of the professionals that you didn't mention was the psychologists, because the non-motor symptoms include symptoms like depression, and people really need a lot of support. Both the people with Parkinson's and the caregiver network need a lot of support to be able to drive this, and that's a major part of the healing process. I'm going to move on to Dr. Fadipe. I'm not going to let everybody answer every question because time is fast spent. The next question is about partnerships and shared responsibility. From your perspective, what does meaningful collaboration between government, the private sector, and NGOs look like in practice? What should it look like? And how can these partnerships directly improve access to medication, rehabilitation, and long-term care for people with Parkinson's?
All right, that's a very good question. And that question also applies to every disease condition, if I may add. But the first thing is there has to be an integrated, coordinated care system. She already mentioned it when she was answering the second question. From non-specialist caregivers down to referrals, down to medication, there has to be an integrated care approach. She had mentioned not only the specialists are important in the chain of care. You have nurses, community health workers, you have caregivers, all the way down to getting medication. Now, for the government part, that system has to be strengthened. Care has to start at the primary care level and at the community level. People have to be trained to be able to identify the early signs and symptoms of Parkinson's and be able to quickly institute a referral. Now, the referral can be physical, to a physical facility, or through telemedicine, like he has also mentioned, especially in the community level that is far from, a physical facility. Now, when it comes to partnerships, government can institute legislation around medication. We want medication to be available at low costs so people can afford it. Creating a legislation around specific medication to ensure that they are at a fixed, affordable cost is what government can do. And we're looking at the pharmaceutical sector now, where we're talking about supply chain. Low margin supply chain costs is another problem, okay? Because, you see, the reality is everything is interconnected, and funding and money is always at the bottom of all conversations. It is just the reality of it. How do we have conversations with government in ensuring that pharmaceutical companies are given the support to locally manufacture medication? And even when they bring in medication, there is a legislation around the costing for them such that their margin is maintained and the cost is still preserved at an affordable rate. So these are the conversations we can have to ensure that people who have Parkinson's can have coordinated care, access to their medication at affordable rates without having issues of stockouts or unavailability of drugs.
Thank you, well said, because that brings me back to something, I don't know if it's still true, but 4 years ago, when we asked why Roche was producing in Ghana and not in Nigeria, because we do not have a manufacturing company in Nigeria that is producing levodopa, carbidopa, they were told, or we were told, that they have to pay $50,000 to register the drug before they can actually be licensed by NAFDAC to manufacture here. Now, if you pay that kind of money, we don't have the population to actually take up the supply, to make economies of change, to make it worth it. Therefore, they don't. Therefore, we're still importing, and that's part of why it's expensive. So I'm glad you actually mentioned that. Now, what we haven't talked about here is the private sector and how we really need to be one with the private sector and to get more involvement in the Parkinson's ecosystem. The pushback we have had when we've reached out to private sector operators is, oh, but it's not a pandemic. But how many people have Parkinson's? Why are you focusing on Parkinson's? And what I keep under my tongue is, Koti Koini. Let me translate that to English. It's not your turn. That is why you haven't understood it. But as Professor Kubade just said, it's the fastest spreading neurodegenerative disease in the world. And secondly, the lines have come down. It's not an over 60 affliction. People well below, we have somebody under 30 at the center. So, and there's a lot of women, there's young people. So this is happening. We talked about, the question included nonprofits. Well, the summary is that the partnerships have to work together. Do you want to add anything to that, Ufoma? Oh, no, just to talk about how partnerships, meaningful collaboration.
All this policy stuff, not many people understand it. What they want to know is how do they get drugs cheaply. All these collaboration systems, digital, I'm even lost while they're saying it. all we want is let us get these drugs available. Even if we can do more research on local treatment. I'm sure people had Parkinson's before in Nigeria, before modern medicine came in. Maybe we should go and study them. There's this, if I can go on, there's this mucinaprine, I think they call it velvet leaf. Mucinaprine. It's a medication, or not a medication. It's like
from a leaf.
Yes, from a leaf. It has dopamine. Yeah, it has dopamine in it. So if we can develop those local alternative treatment, maybe it will help to relieve people.
Not maybe.
It will help.
Not maybe. What we said 2022 the day we opened the foundation is that we don't know what lies in our forests. We don't know what lies in our leaves. We don't know what lies in tree barks. Dogonyaro was always something that was taken for malaria. They sell things in the market. You go to Elewe Omo section, and they have all sorts of things there. But what we haven't done is we haven't spent enough, time and money. We need to get into research. We need to get into research, and we need to invest a lot more of our resources in trying to find a cure for Parkinson's. And like I said then, and I'll say now, we don't know if the cure for Parkinson's is in the forest. And we watch TV and we see what happens on African Magic, and they put one leaf here and whatever. But because of a lot of religious translations from our own native religions, we've moved away from those things. And it's important that as part of research, we go back into that space to do research and find out what powers we actually have.
Let me quickly add something. Please, I'm not advocating to take drugs or take anything at random, even if...
No, I hear you. So what you're also saying is that if you are taking carbidopa, levodopa, stay with your medication. Don't add dogonyaro to it, because at the end of the day,
we can't figure out which one is working. And if we're going to do research and we're going to observe patients out in the rural areas, we'll be looking at patients who are taking these things exclusively and not a cocktail.
Yes?
Yes?
Yes. Yeah.
Thank you. All right. Let's not say anything dangerous. Okay. I think we're rounding up, and it's basically we cannot work alone. We can't work alone. People with Parkinson's can't walk alone. It's together with government. It is together with the whole medical system, with the private sector, with non-profits globally, that we can improve access to medication, rehabilitation, with the insurance man, yes, and long-term care for our patients. Dr. Feripe, in 10 years' time, 2036, what do you think a truly sustainable Parkinson's care system should look like in Nigeria? Let me finish. Ms. Ahigbe, get ready to add to that. What must we start doing differently today to make that future a reality for people living with Parkinson's in Nigeria?
Okay, in 10 years, okay? For me, at that time, I expect Parkinson to be an integrated part of health insurance, because that is the only sustainable way that you can ensure that people are properly taken care of. But before we get there, Professor Okupeyo mentioned data. We need the financial data. You see, health insurance is basically based on data as well. Like she said, data is used to make decisions. When a plan is going to be developed to determine what are the things that are covered, data is used. How many people are affected? What is the cost? What is the cost of an untreated Parkinson's condition? What is the cost? If I don't treat Parkinson, what does it cost me? From the hospitalization, from fall, someone falls down, the caregivers that the person will have who will burn out after taking care of the person for so long, what is the cost to that person? That data is important for us to say, okay, we have this population affected, this is the cost. That data can be used to say, this is how we can incorporate Parkinson's coverage in health insurance and ensure that if you have Parkinson's and you have health insurance, you are covered for medication, physical therapy, and every other care from beginning to end. Because this is the real conversation we need to have, okay? And again, but right now, what can we do? The first thing we can talk about is, first of all, we need to advocate. Advocacy is important through the civil society groups to ensure that government starts considering incorporating Parkinson's into health insurance coverage. That's number one. Number two, the data I mentioned, we need to start looking for how to gather that data. What does it cost to ensure that Parkinson's is taken care of? We need that data. If you have an idea of the cost, it helps, because that is what government will use to determine how quickly it can be incorporated. The other one is you can do a pilot community program, starting from the primary healthcare centers. How can people go to a primary healthcare center, see, a healthcare worker that is a non-specialist, a nurse, a community health worker, a caregiver? How can it start from there? Because we talk about it, but nobody is doing anything about it. Can we pilot it? Let's say over a 6-month period, people are trained to identify the symptoms and then issue a referral. Like I said, referral doesn't have to be physical. It can be through telemedicine. And then they can identify it. So let's even do a pilot of it, see how it works, and see how we can integrate that system into it.
Primary health, you're nodding. Yeah. Okay, we're with us. Ms. Ahigbe.
Yes, ma'am. Okay, thank you so much for that. I think.
Mute her, please. Media.
Oh, I'm sorry. Can you hear me? I'm actually not muted from here. Can you hear me, please? Please, can you confirm if you can hear me?
We can hear you.
Okay, maybe you can say something so I confirm if I can hear you.
We can hear you loud and clear.
Okay, all right. I'll just go ahead. I can't hear, but I will just go ahead. So I mean, to answer the question, if we fast forward 10 years, I think a truly sustainable Parkinson's care system should feel much less fragmented and much more predictable for the person living with the condition. It shouldn't feel like a journey of luck. It should feel like a system that lasts. And I think what we've heard today makes that very clear, especially around cost, just like the speaker before me said, around access and support, shape the experience just as much as clinical care. So for me, a few things would need to be true. First is earlier detection. Earlier detection should be normal, not perfect, but normal. People shouldn't have to spend years moving from confusion to clarity. The people closest to community should be able to recognize early signs and help trigger the next step. The second is care should be more distributed and connected. Not everything depending on a few specialists in a few places, but stronger links between community care, primary care, specialist support, rehabilitation, and long-term follow-up. Third, and very importantly, given what we've discussed today already, costs should not be the point where care breaks down. Financing has to be part of the design from the beginning, because long-term care is not really sustainable if it is only available to those who can keep paying for it. Fourth, care should be multidisciplinary, because Parkinson's doesn't affect just one part of life. So the response shouldn't either. It has to include physical support, mental health, rehabilitation, caregiver support, and also ongoing guidance. And then finally, the system should be easier to move through, where data and digital tools support coordination, not as an extra layer, but as part of how care actually works day to day. Because for me, the real definition of a sustainable system is very simple. The person living with Parkinson's should not be the one holding the system together by themselves. That is the future that is worth building. And if we want to get there, it means being more intentional now about how Parkinson's care is integrated into the broader health system, how partnerships are structured, and how financing is considered from the start. Because sustainability does not begin when funding is abundant. It begins when the system is designed to last. So that would be my thought on that. Thank you.
I just want to put on record that we're in partnership with you and eHealth forever, and that we love the way you work and the way you have very people-centered approaches to improving things. So the next 10 years, we are holding hands together. Thank you very much for your contributions. Ladies and gentlemen, the afternoon is fast spent. And, well, not fast spent, the afternoon has started, but we should be out of here. I'm just going to try and recap. Basically, what we're trying to achieve is how to center the voices and the lived experiences of people living with Parkinson's and shape the care systems. We're trying to close the gap between patients and healthcare providers, policymakers, non-government organizations, the private sector, and the entire support ecosystem. We're going to work together to identify practical, scalable solutions to workforce access and care delivery challenges, and hopefully drive a shift from short-term support to sustainable long-term care systems. Parkinson's care has to be people-centered and has to be community-driven. And workforce strengthening in the multidisciplinary approach is absolutely essential. We cannot do this without sustainable partnerships, critical to improving access and outcomes. And there's need for long-term financing, policy commitment, and system integration. All of this is non-negotiable. I'm going to use this time to just thank you all for being here. Thank you, especially those who have stayed. Now, bringing the symposium to Muson was ambitious because for the last 3 years, we've held the symposium at the Adeomide Salu Parkinson Center in Surulere, which sits about 150. And we've really not done more than 150. But we decided that in 2026, we were going to step it up. And we thank you for making it a reality that you are here. And technically, we could have filled the room if they didn't spread the room so far left and right and fill it to the back. We could have had a tighter cluster. But we're looking forward to seeing you next year. It is April 11. The date will, well, next year it may be a Sunday, so that may be something. But even if it is a Sunday because it's World Parkinson's Day, we may have it in the afternoon. But please put it in your diary that World Parkinson's Day is a date with the Adeomide Salu Parkinson's Foundation. Thank you all. Thank you for your time. Thank you to our panelists. Thank you to those especially who traveled. Thank you to the people online. We have quite a lot of people online who have listened, people who have posted questions, people who have participated without being here. We thank Professor Frandalfa. We thank Professor Campanello. We thank Ms. Ahibe. Who else was a panelist online? I think that is it. Thank you very much for your time, for your love, for your sacrifice. And it is our prayer that all of us will see the rewards of the time we have spent here today. We've all been given tasks to work on. We have to work with government. We have to ask for more. Dr. Shopekon is here from Abuja, and we're going to hold on to you. We're coming. And Lagos State, we're coming. And Ogun State, and Oyo State, and Delta State, and Nasarawa State, and Kebbi State. And anyone living with Parkinson's in Nigeria is going to begin to see that things are changing and that we see you. Thank you. Thank you to the caregivers. Thank you to wives, to children, to all the family that is looking after somebody with Parkinson's disease. Thank you. May the Lord strengthen you. And we will stand, and hopefully the cure for this is coming soon. And together we work. We thank the students from Lagos State University. We thank the students from the College of Medicine, University of Lagos. You are the tomorrow. You are the 2036. You are the ones that we are praying will stand and will speak and will tell us what we don't know now. And God will help you to get there. You will succeed. Thank you. Thank you. John Akinola.
Can you put your hands together for the panelists, please? You can rise, and thank you very much for your time. We are bringing this to a close. Please, while they have the group photograph, please, okay. All right. Please, I think you should have Ms. Aikibe on the spotlight so she can be captured also. All right, while we are doing that, when you were coming in, you know, there's something that is in your, it's just a donation, because putting together activities like this comes at a cost. And we want to encourage you. No amount is too small. You can give. So before you go, please, you can just write what you would like to donate, or if you want to make it a one-off, a continuous donation, or you can scan the back of the donations card and just make your donations immediately. Thank you very much. Would like to appreciate everybody for coming. We are rounding up and we are leaving this place. And if you look at your program, the program you have with you, we are meant to end this by 1. And we are getting there. We just overshot with 20 something minutes. So, Mrs. Desalu has given us the vote of thanks already, so I wouldn't want to stretch that. We want to appreciate every stakeholder that we have here, both from the police to the Federal Road Safety Corps, LASMA, and we are bringing them. We invited as many people as possible because we wanted them to have a buy-in into the Parkinson's ecosystem. Because a lot of people, while walking on the road, you see them freezing or having tremors. Don't discriminate. Please help them. And for everyone that is either newly diagnosed or is trying to find his or her footing with the diagnosis, we want to tell you that the Adewumi Desalu Parkinson's Foundation is here for you. You can reach out to us. We are online, we are offline. We have a center at Surulere, Lagos, and we want to appreciate you as you refer people to us. The media team is going to put up a barcode that you can scan, and that barcode has a lot of information about some of the activities that we had here today and some of our activities that we have and the impact report. Please make sure you snap it and you scan the barcode. All right, okay, please. Okay, let me, so please scan the barcode and you will have this information. Okay, please, I would just want to say this. Somebody pick out your phone as you are scanning. Also, scroll to July 25th. July 25th. July 25th is a Saturday, and that day, the Adewumi Desalu Parkinson's Foundation is planning an awareness walk. That awareness walk is just a 2-kilometer walk, but to raise awareness about Parkinson's. So save the date on your calendar. We want to see you. We would like to have you walk with us. July 25th. July 25th. It's a Saturday. Saturday, July 25th. Please save the date on your calendar. We want to see everybody. We want to see your beautiful faces. We want to walk with you. We want to walk with the Parkinson's community. We want to have an awareness that will raise an advocacy that even the state government and the federal government will come and say something is going on in Lagos State. So please save the date and let us work together. Are we done scanning this? All right. Thank you very much. We are going. So before we go, one of the members want to give a vote of thanks. The members, we call them members because we don't want them to be stigmatized. One of the Parkinson's community member, a PD warrior. Please put your hands together for Mr. Isons. Put your hands together for him. Thank you. So while you're doing that, if you have your card, if you want to make any donation, just call any of the ushers and give. Please, you can come up stage. Let's thank you. All right. Thank you very much. Welcome.
Good afternoon, everybody. I give thanks to everybody that are here today. It is not easy to leave everything you have to do and be here. This place I'm standing, all the people in the hall are watching me because my hands are shaking. And without shaking, you are not having Parkinson. So it is a sign of Parkinson. So I'm giving thanks to everybody. Today's symposium opened my eyes to see what the people of ADPF are doing, to see that our welfare is taken care of. When I look at my left hand, I saw a young generation coming up to take our course. I am old, and many of us that are warriors are old people. Our own is gone, is going. But I trust that with time, God's will be done in our lives in Jesus' name. My thanks goes to this ADPF. They are wonderful people. In fact, I will say that ADPF is the people that make me to be alive today. When I was diagnosed in 2021, and I asked the doctor, what will it take me to be cured? He said that there is no medicine to cure it, that I have to be managing it. I withdraw myself from everything at all. In fact, I'm a living dead by then, until I was introduced to this ADPF. When I go there, I saw many people that are in the wheelchair. Some are not moving their foot. Some are not moving at all. Some are not eating by themselves. But I can still drive. I can still eat. I can still dress myself. Then I said that God blessed me much, much more. That they make my life to change. Because when I withdraw myself from any activities, I was thinking that my own is gone. Let me give you an example. When the AIDS comes out, it is not the AIDS that kills many people, but their conscience. They will think that once there is no cure for it, that they are gone. They will not come out again from their shell, and that is the end of that thing, until there is something that will make them live for long now. So my hope is that this new generation will take care of this disease, which I wouldn't even wish my worst enemy to have it. It is very dangerous sickness.
in person.
Recording stopped.